Okay. All right. So thanks, Amy. So the first measure up right now is patient understanding of key information related to recovery after a facility-based outpatient procedure or surgery, patient-reported outcome performance measure. So the CBE 4210. So this measure assesses how well facilities provide clear, personalized discharge instructions to patients with 18 years or older who had a surgery or procedure at an outpatient facility. It uses a 9-item survey to obtain patients' feedback on 3 domains: applicability, medications, and daily activities. So the facility scores are calculated by averaging the individual patient scores for each facility, and individual patient scores are calculated by using a top box approach. So that's measuring the percentage of the total number of items given the most favorable responses, so like a yes or a very clear, out of the number of relevant items. Mentioned the developer is Yale Core. This measure is stewarded by CMS. It is a new measure. Its current or planned use is for public reporting and quality improvement, as well as quality improvement with benchmarking. As mentioned, this was a patient-reported outcome performance measure. So it's using a survey to collect input from patients. The patient population is adults 18 years of age and older. The care setting is an outpatient, and it is the level of analysis is for the facility. Go to the next slide, please. Okay, so we received 2 public comments on this measure. Both of those were supportive of the measure, supporting that it's personalized, clear discharge instructions are important to patients to follow through on compliance of medical recommendations, and that outpatient procedures are becoming increasingly common. And this measure allows for a comparison between provider locations, resulting in patients being more informed. So again, 2 public comments. So at this point, as the next step in the process, we will also pause to see if there are any members of the public on the call today who'd like to voice any public comments for this measure. Again, we ask that you keep your comments to 2 minutes or less. To be recognized, you would raise your hand from the attendee list, and we will call on you accordingly. Okay, any member of the public who wishes to have any additional comments added to this measure? Any member of the public comment? Okay, I'm not seeing any hands raised. Okay, so with that, let's go back to the previous slide, please. Amy, and I'll turn it over to you for a 3 to 5 minute overview of this measure.
Terrific. Thank you so much, Matt. So I'm pleased to introduce this measure. The name is kind of a handful. We use information transfer ProPM for brevity. On behalf of the Yale Centers for Outcome Research and Evaluation, which developed this measure under contract to CMS. I'm also joined today by a whole team, including my colleague, Dr. Ramon Simmons, who led the development of this measure. Not going to go over the definition again, but I do want to walk through the calculation of the measure because I did see there were some questions about that. So the survey was piloted using a web-based mode. For clarity, that web link can be sent to the patient via any available method, email, text, patient portal, whatever suits the patient's preferences and was within the capabilities of the facility. All of the data elements that are needed to identify the eligible patient population are in well-defined standardized electronic fields. The 2-midnight calculation referenced in the specifications simply mirrors CMS's guidance on what constitutes an outpatient encounter. And so that is intended for to make sure that we're only including outpatient procedures or surgeries. And again, the elements needed for that calculation are in very standardized EHR fields. Only complete surveys are included in the measure. So patients with incomplete surveys are ineligible for the denominator. They do not fall into the calculation at all. The score uses a top box methodology. So the number of items the patient scored yes or very clear divided by the number of items the patient deemed applicable to them. Not all items may be applicable to all patients in all situations. Those individual scores are then averaged to arrive at the hospital score. So it is an average of those individual patient level scores. We do want to note that the pilot or testing for this measure took place while the outpatient and ambulatory surgery CAPS was in voluntary implementation. So we were competing for scarce resources with facilities who were trying to bring one of their first pro-PMs online. The information transfer pro-PM is designed to leverage that infrastructure that was put in place for OAS CAPS, which is now in mandatory reporting, while also minimizing burden. There are no overlapping questions between the two surveys, and the surveys are administered in different timeframes, so they would not be coming to patients at the same time. The items used to generate data for this measure have been psychometrically evaluated and demonstrated evidence of both reliability and validity, including signal to noise reliability and face validity. As noted in the committee feedback, the measure is not risk adjusted. During development and testing, CORE analyzed the effect of adjusting for patient factors identified in the literature. There were no statistically significant differences between adjusted and unadjusted scores. In addition to this empirical analysis, stakeholder discussions were in strong consensus that HOPDs should tailor discharge instructions to accommodate patients' unique characteristics, such as age, education, health status, and prior experience with surgeries. So in closing, we are pleased to share that the information transfer pro-PM received strong support during the recent pre-rulemaking measure review meetings and was recommended with conditions, such as endorsement, for use in the hospital outpatient quality reporting program. We look forward to today's discussion. Thank you.
Great. Thank you so much, Amy. Appreciate that. So that was our overview from the developer. So the next step of this is just we're going to go round robin with the committee here, just to make sure that those on the recommendations group don't have any further clarifying questions, either from what Amy also had mentioned or in your reviews prior to the meeting as well. So let's go ahead. I'm just going to go down the list that we had from our roll call. So I'll start out with our co-chairs first. So Mary Beth, any clarifying questions from you for the developer?
Yeah, do you, you said 18 years old and there's no upper limit, is that correct?
That is correct.
Okay. And I think that was the only thing, yeah, that was the only thing I had. Thank you.
Okay, thank you. And Whitney?
Nothing at this time, thank you.
Okay, thank you, Whitney. Amber, any clarifying questions?
No clarifying questions.
Thank you so much. Ashley, anything from you?
No clarifying questions.
Thank you very much. I know Chris, are you on the call? You weren't here during attendance, but Chris. Yeah, okay. And David May, David, or did you come back? You had to step away just briefly. Okay, we'll circle back on that. Eleni, any questions from you?
Eleni, no questions at this time. Thank you.
Thank you. Thank you. And I believe Jason, any questions from you? I think he had to step away just briefly. Yeah, okay. Jill Nagel,
yeah,
any questions from you?
Just one quick question. I'm thinking that some of these patients will be eligible for other pro-PMs. So are there exclusion criteria, or could the pro-PM sets a patient is eligible for start to stack up, like thinking of hip and knee, for example?
Amy, would you like to address that?
Certainly. There are no exclusions. It is all outpatient procedures and surgeries. That said, we did consciously try to set the time frame for this to be different from those other surveys, so that patients won't be hit with a lot of surveys at once. And we did also harmonize to avoid duplication of any survey items with those other surveys.
Okay, thank you.
Thanks, Amy. Thanks, Jill. And Kyle Holtz. Any clarifying questions?
This is Kyle. No clarifying questions at this time.
Okay, thank you. Marissa.
No
Anything from you,
clarifying
Marissa?
questions. Jill asked the question I was thinking about. Thank you.
Great, thank you. And Marjorie?
No clarifying questions.
Thank you so much. Monique, you weren't on earlier, but if you're on now, Monique Sartor. And Nasir Khan. Okay. How about Raquel? Any clarifying questions from you, Raquel?
None for me, thank you.
Thank you. And Sarah?
No clarifying questions.
Thank you. And Vilma?
Hi, did you think about extending it to beyond just 2 languages? Because it's in English and
Amy?
Mhm.
Yeah,
Certainly.
great question. So asking if there's multiple languages for the survey. Go ahead, Amy.
At this time, we do only have the English and Spanish in terms of what's been tested and validated. However, it could be implemented with the use of an interpreter. It does also allow for proxy or caregiver survey completion, and certainly open to translation into additional languages. Somewhat nuanced by facilities in terms of population on that.
Okay, thanks.
Okay, great, thanks, Vilma. And lastly, for our recommendations group, Yvonne, she wasn't here during roll call, but just checking in. Yvonne, she had mentioned she wasn't feeling good today. Okay, all right. I also wanted to just touch on a couple others, Amy, just from some of the recommendation, or excuse me, the advisory group questions. One was the survey uses a 9-item survey to obtain the patient feedback on 3 domains like applicability, medications, and daily activity. The question was around applicability. It's mentioned as one of the 3 domains, but it wasn't really clear from the survey instrument where applicability was, because there was indication of the other 2 domains about medication use and daily activities. Is it assumed that applicability was the first couple of questions or somewhere else within the survey?
Yes, applicability, I believe, is the first couple of questions, although I will
I'll take that.
defer to Aman if she has anything else to add on that.
So there's 2 different applicabilities. There's the applicability domain, which is basically how relevant was the information that you received concerning your home environment. And then there's the general question of like, for the questions in the remaining domains, is this applicable to you? So, you know, it's like, if you don't drive, then it's not important to you whether or not, you know, somebody told you you could drive, or if you had a surgery that doesn't like affect your ability to drive. Say you had, you know, a sort of like an IND, or if you had, you know, some procedure that didn't affect your ability to drive, that question is no longer applicable to you. So there's the applicability domain, and then there's whether or not this question is like a yes, no, or not applicable. So applicability domain is about, like I said, considering your home environment and your resources. And then, you know, so like if you have you know, if you live on the 5th floor of a walk-up, you know, your discharge instructions should, and you know, you had an RIF, it's kind of important that somebody sort of consider that in your discharge and tailoring information to you. And whether or not, you know, the surgery is important, like whether or not each question is applicable to you, given the procedure that you had, et cetera. So there's 2 differences. I hope that was clear. Thank you.
Yeah, thank you. It was. I also had a sort of follow-up to that as well, because it mentions how the score is calculated for each one of the respondents by taking the sort of the sum of the items for which the respondent gave the most positive response, like yes or very clear, and dividing that by the number of items for the respondent being applicable. But it looks like only 7 of the 9 items actually have do not apply. whereas the first two questions have like a no as one of the options, but they don't have a do not apply or that not applicable type of response. Are those no's to be determined as like a not applicable in that case, or how else would it might be interpreted, or especially for the calculation?
So the first two questions are about their applicability. So it's generally about the information being, like I said, did the information take into consideration your like your home environment, and so it's not, regardless of what procedure or you had, we felt that, and RTEP felt that, like, in reviewing these questions, that the information and should be tailored to a specific person. And so that's why they don't have the does not apply, because it's not like it's not about whether it's specifically about whether or not your health needs and preferences and your personal situation was taken into account, and that should not vary based off of the procedure that you had. Like, the information according to the literature should be personalized for it to be effective, and so people should be asking you questions about what your preferences on medication management are. Most procedures come with, pain medications. They should be asking you about, your transportation. This is like a sort of outpatient facility. You're going to have to go home 4 to 6 hours after this procedure. And so knowing whether or not a person has resources to, like, for somebody to pick them up beforehand, and taking into account their personal situation, we felt that was applicable to all patients, which is why that does not apply isn't included, because the first two questions are about, assessing whether or not the information was personalized and took into account their needs.
Okay, thank you so much for that. All right, any other further clarifications based on even what the developer has responded from the recommendations group before we go into our first series of discussion? Mary Beth and Whitney, anything else from you both or from the patient perspective? Okay, not hearing any.
Nothing from me.
Okay. All right. Great. So, and thanks, Whitney. Let's go to the next slide, please. What we're going through, sorry, and the following slide after that. So now we're going to start with importance. So if you remember that dashboard slide, we had all of the ratings from the committee members that submitted votes prior to establish where there might be consensus on a given domain. This is a little bit deeper into that domain. So these strengths limitations are what's been aggregated from those reviews and what we'll use for the purposes of our discussion today. So we also had those staff preliminary assessments, right? So those staff assessments which help to identify, as staff reviewed the measure, where they rated each one of those domains. And for this first measure, under importance, the staff preliminary assessment was a met. And the staff assessment did also identify the similar strengths that were identified from the committee and independent reviews, which the developer provided a logic model that connects this measure to other downstream outcomes, supported with evidence, as well as some committee members that the developer also had convened, as well as patient members on a panel that they convened, actually rated that this measure is important, as well as to help reduce poor outcomes with patients. The developer also had claimed that the measure would add value to the existing portfolio and aligns with the CMS's national quality strategy. Now, there was a limitation identified here. Some members just mentioning that the literature review could have been a little bit more robust. It doesn't really clearly connect those improved patient understanding and outcomes very clearly. So I'll see if the recommendations group has any felt the same about these limitations, or did you have any concerns about the evidence to support this measure? Again, this is supporting the business case that there is a gap in care here. This measure would actually improve outcomes, so the existence of this measure is important based on what the developer has submitted. So open it up to the recommendations group. Any thoughts from the group, especially on this limitation? And if you feel like you didn't identify that limitation, please go ahead and state that. Any thoughts? Anyone on the group didn't find that to be a limitation? Want to speak up at all? So if we don't hear any, it means, oh yeah, go right ahead.
Yes, it's such a big point trying to get information from patients in terms of figuring out their level of satisfaction. So I think this is a great first step, and trying to use different mechanisms is wonderful. And in terms of the literature review, because it's been such a pervasive problem, I didn't think that you need to have because it is still a problem. I don't think you needed to have more up-to-date affirmation that we need to address it.
Okay, thanks, Vilma. So recognizing this is an important area, important issue, no major concerns with the evidence there, okay? It sounds like that might be the same for the others in the recommendations group. And again, I'm not hearing anyone speak up to say, yes, I found the limitations of the evidence to be significant here. Does anyone else have anything else to add to this or the evidence that you reviewed? Yeah. So I'm going to take it that not hearing anything from the recommendations group means that you find that the strengths are really good, the evidence is really good, and it supports the business case. Okay. All right. Okay. All right. So let's go to the next slide then. So the next one is on feasibility. Also had consensus here. You can see about 82% here being met. Just a reminder of what we're thinking about with feasibility, as you can see it stated up there, is like really understanding if the measure specifications require data that are readily available or they're captured without any undue significant burden, especially from those being held accountable and implementing the measure. So there are some strengths here that have been identified, and the staff preliminary assessment was also met for this, recognizing that the measure does have fewer survey items on there. So, you know, that's helpful for when you're thinking about burden. It's multimodal survey administration is an advantage on this one, but there are some limitations here that maybe we can have the developer speak to a little bit, some of which was about some of the different modes of delivery. And there's also a comment here on burden to some facilities may be significant, such as Medicaid agencies may struggle to collect this information. Testing may not be adequate due to some burden on those facilities and lack of clarity on how the measure is scored from the survey items as well. So maybe Amy, would you mind, or someone from your team, maybe we could start out maybe speaking to some of these limitations first, and then we can kind of open it up for the recommendations group if they have any further follow-up.
Certainly, I can speak to these. In terms of the survey mode, I think we did cover that the survey could be texted, the link. It's a website, and that was the mode. So any way that URL can be sent to patients, that would work. We actually anticipate implementation would be less burdensome than it was in testing because of the infrastructure that's been put in place since then. Hopefully cleared up the clarity on how the measure is scored. I was intrigued by the thought of administering the survey before discharge. I believe our thought on that, and in my experience as a patient, is things can seem clear in the moment, and then when you need to kind of implement the discharge instructions, I think that's when there could be questions. I certainly think there are things that facilities could do to ascertain the clarity, using teach back, having patients restate, and there's nothing stopping them from asking these questions, certainly prior to discharge verbally, so to enhance understanding. In terms of Medicaid and other payer organizations, such as private purchasers, they would probably need to request this pro data from the facilities themselves, or utilize, if it is eventually publicly reported on the compare sites through CMS. Those are ways that they could get access to that data. It is a challenge as a purchaser or a non-CMS organization to get pro data. We do recognize that.
Thanks, Amy. So speaking to some of those limitations listed there, which we talked about, different modes of delivery and obviously the different languages, but anyone from the advisor group have any follow-up questions on that? Again, thinking about feasibility here, how feasible this survey is to implement, any burden that may have with workflow, anything else to add to what Amy had mentioned, or have another question? And
Hey,
feel
Matt,
free
I
to
just
either come
wanna-
off mute or recognize you. Yes, go right ahead. Who's this?
Sorry, it's Whitney. I wanted to just recognize the comments that had come in, reflecting the issue around mail surveys and how this tends to skew then towards the negative. And I think it's just important to recognize that from a feasibility perspective, finding additional opportunities for survey respondents and adjusting that going forward, and perhaps a later measure might be valued. It certainly didn't shut down anyone's conversation, but it is a consistent pattern of just, this is kind of like when surveys had to switch from calling landlines to having more creative opportunities because that was skewing and biasing the data towards a certain part of the demographic. I think we're at a similar crossroads with this one. But obviously anything that can be done to enhance discharge instructions is a win for patients, because it's certainly been limited historically.
Great, and thank you, Whitney. Was there anything we wanted the developer to speak to on that, or it's just some additional considerations for the developer?
Just additional considerations for the developer. I apologize for making my question in the form of a statement.
No, you're good. You're good. Perfectly fine. Amy, was there anything you wanted to speak to on that? Anything in addition?
No, I think we've found that access to completing things on the web and doing surveys on the web is pretty widespread in all patient populations, and a little greener maybe than all the paper surveys, but your points are well taken. Thank you.
Great. Eleni, you have your hand raised. Go right ahead.
Hi, is there a timing, and this may be already indicated in the specifications, and I apologize. Is there a timing component in terms of when this is being evaluated? Is it expected that these results would be evaluated on a monthly, quarterly, or annualized basis? Because if we're sending out surveys in a variety of different ways, they can come in a variety of different ways and time periods. Is there a timing consideration that was evaluated for the survey?
Okay, asking about a timing consideration for this survey. Amy, any response on that?
I believe the intended period of performance is annual reporting, but implementation is somewhat out of our control. We did set minimum survey counts that would be required, but the final implementation of the measure is within CMS's purview.
Thank you.
Thanks, Amy. All right, I'm going to keep the conversation kind of going. Any final questions on feasibility here? Looks like some strengths identified here and some discussion with the developer about some potential considerations. Not really hearing a condition placed on here, but maybe just some recommendations for the developer to consider. Whitney or Mary Beth, any would you agree with that? Anything else we missed?
Go forth.
Yeah, no, I think you covered everything, Matt.
Okay, all right. Let's go to the next slide. So we're going to get into signs of acceptability. Now, the signs of acceptability was broken out into reliability and validity during the committee independent reviews. If we use the lowest of the two, so the lowest sort of percentages of the two, just to draw out some of the limitations that may be identified. So here we have consensus, but it was consensus on not met but addressable out of those 22 that evaluated the measure independently. And again, when you think about reliability and validity, it's extent that these specifications are clearly specified and that they're precise as well as credible. If you think, as well as the measure score itself, if there's score level testing, the developer does look at the score, making sure that the score is a true indicator of quality, and the score can actually be precise in estimating where there are differences in care, so reliable and valid. But we're going to combine the two for discussions today and kind of going through that. Now, during the staff preliminary assessment, it was also not met but addressable, and this was due to some of the, maybe some clarification around the denominator specifically, as well as how the definition of midnights was determined in relation to the denominator definition. There was a smaller sample size with testing, but this is a measure that does require a lot of prospective testing using a lot of different test sites. But there was a small little sample size used for this. 15 was that, but you know, there could be potential for other type of testing down the road. And the developer didn't find statistical significance with their empirical validity testing, where they looked at testing this score with another indicator of quality. It was in the expected direction as they hypothesized and the magnitude, but it wasn't necessarily statistically significant. So some of the other limitations, some of which we've touched on here within the staff assessment, just more clarity around that definition. There was some face validity as well, concerns about just not knowing what the panel composition was, and then the validity testing of that measure had some limited sample, may have yielded the non-significant results. There was also a comment saying that it was not risk adjusted either. It is an outcome measure, patient-reported outcome instrument-based measure. So maybe the developer can speak to the decision of not risk adjusting also. So maybe Amy, if you wanted to start with some of these, just touching on some of the limitations, we can open it up to the committee to see if there's any additional things they'd like to add to that.
Certainly. As mentioned, we did run into a challenge with kind of competing for resources against OAS caps, and also the HIP-knee pro-PM, which was previously mentioned. So we were asking a lot about patient facilities during this time frame. This impacted both our ability to implement in a broad testing sample, and also we ran into challenges with comparison to OAS caps because it was involuntary reporting and was not in place at all of the facilities where we were testing. So some were still implementing OAS caps. So we did not necessarily have results for all of the facilities. And so that was a challenge with validity. And we were very close to hitting the p-value we wanted, but not quite there, which means we didn't meet it. In terms of face validity, I will need to find, we can find the panel composition and listing. Apologies for not including that in our submission. In the new form, we missed that checkbox, but we'll hit it again if next time we submit. I think we've already spoke about the calculation and the risk adjustment, and I'm working on finding that listing of who was on the top.
Thanks, Amy. While you're confirming that, how about the committee? Any additional points on these limitations or others that, even through some of your review, that you want to ask related to science acceptability? Again, thinking about the validity of the measure, reliability of the measure. Any questions from the group, the recommendations group? Okay. Okay. Amy, in addition, wanted to also ask a little bit about the survey instrument itself, and maybe the approach to developing it, or was this something that already had been developed under another entity? Just maybe the survey itself, if you could speak to sort of maybe that approach, because there were some comments, and including the staff's preliminary assessment, that mentioned just asking if the survey instrument was also valid and reliable, or at least the approach to it, asking a little bit more about that as well. Yeah.
Certainly. This is a novel survey that we developed de novo, so it was not based on existing surveys. And it underwent iterations as we went through the testing and the evolution. It was originally a much longer survey with additional domains. We had concerns about overlap of some of those domains with the existing OAS caps, and so we're able to remove some questions from that. Also responding to patient feedback on length of survey and technical panel concerns. We did maintain internal structural integrity of the survey, which I'd have to look at the exact testing, or Iman probably knows it off the top of her head. But we did look at whether all items were valid and reliable within the survey itself.
Thanks, Amy. So you did look at the items themselves in the survey were valid and reliable. Okay.
Yeah.
Yeah, go ahead.
We used a Cronbach alpha test that looked at the internal consistency. So essentially looking that the items within the survey were in agreement with the overall validated reliable result. The reliability on that was very strong.
Great, thank you. And any update on the composition of your TEP for face validity?
Sure. May I screen share that? So there were 15 panel members, including 2 patient representatives on the TEP itself.
So 2 patient representatives, maybe. What about the other categories for the others? You know?
Sure. The specific categories we sought were patient, someone clinical practice. So we had several representatives for that. Care coordination, as this area is related to that. Quality measurement and survey design and analysis. Performance improvement. Healthcare disparities, and then payers or purchasers. So those were the specific categories we sought in convening the TEP. And then in addition to the TEP, we also had a patient and family work group as well.
Great, thanks, Amy. So for the recommendations group, this was a not met but addressable, and we had a series of limitations listed here, and Amy and the developer had provided some responses and remarks to those. Were there anything else that maybe you found was not addressable from the recommendations group, based on either on your reviews of comments or public comments, et cetera, that you would also want to confirm, thinking about if there's something that's still not being addressed in this conversation here with the developer or through your review? And I'll also ask if Mary Beth or Whitney have any other additional comments on that question as well from their perspective, but any from the recommendations group. So not hearing any, it sounds like the limitations that were identified, the developer has addressed. If that's not the case, please speak up. But Whitney, Mary Beth, anything from you both?
Not at this time.
Amy, you don't have any exclusions, right, for this measure, is that correct?
That is correct.
Okay, what about folks that walk out against medical advice? I know that's very rare in outpatient place, but that may be an issue. Do you still want to get information from them as, you know?
That's a good question. I believe we'd still want information from them. An interesting nuance could be if they left before receiving all their discharge instructions. I assume it's a rare occurrence, but
it's a rare occurrence, or, you know, maybe they just changed their mind about the surgery or something like that. But again, you know, it's one of those that if you do send out a survey to them, that might kind of skew it a little bit, but not very much, I should say. So, okay. And do you have a rate of return, response rate for the settings you did?
here.
The response rate varies by facility. The overall response rate, unfortunately, was just, I believe it was like the entire sample, including all facilities, including those dropped, was like 10, was it? Sorry, is it 11% or something like that?
Okay.
But the response rate for facilities that were able to implement the survey closer to the the actual sort of requirements was 30%. So it was closer
Okay.
to OAS caps. Unfortunately, because this came out during COVID, and because OAS caps became mandatory, there were issues with what we call the lag time. So we ideally want the survey to go out 2 to 7 days after the procedure. And what happened was we had to get special permission to implement the survey when they were implementing OAS caps, and that unfortunately took more than a month. So yeah, there was a
Okay.
with
Yeah.
the implementation that have really nothing to do with this sort of the capability of the survey. It just was an implementation issue that we struggled around. And then of course, there was a great delay in the number of cases that were being done monthly because of COVID. So yeah, it is a small pilot, but
Okay.
Yeah.
Okay. That answers it. Thank you.
All right. Thank you. And Ashley, you have your hand up. Go right ahead.
Yeah, so I had, it's kind of a two-part thing. The first one is going back to that comment about the AMA, leaving AMA. So I just want to clarify first that we are including, correct, everyone who has received the outpatient procedure. Yes. So, okay. So my, I guess like recommendation would be as a patient, but also as a clinician, discharge starts at admission, right? And so best practices is for us to, in order for us to do discharge planning, we start that before the procedure occurs, which means that this information in regards to follow up after the procedure should have been, that should have started being communicated prior to it being scheduled. And so I don't see any reason that if someone is leaving AMA that they wouldn't be included because as long as they got the procedure, right, that should have happened. So that was just my comment about that part.
Great, and thanks, Ashley. Amy, anything to respond to that, or sounds like you're nodding your head in agreement there?
Yeah, we absolutely agree. We wanted all patients included in this as much as possible. And I believe one of the recommendations we had for facility improvement was multiple touch points with the patient, multiple conversations and multiple modes of communicating the information. So you nailed it.
Just to piggyback off of that, in the introduction of the survey does indicate that we are including all information that they received from the time that they decided to have the procedure until after. So just to further clarify Ashley's point, thank you.
Thank you, and thanks, Ashley. Great question. All right, I'm going to keep moving unless someone has a comment they're really dying to get out there. Not a dying comment, but a comment they're dying. All right. Keep on going. Let's go to the next slide, please. Okay, so this is the equity domain. As I mentioned, this is optional. So a lot of feedback, if you have any for the developers, is some things to consider. Again, this is not something that will determine the endorsement decision, but it is, and you can't put a condition on this either, but it is something for any additional consideration. So for the equity domain, the staff preliminary assessment for this one was not met. It was due to just this response not being fully addressed, no disparity data being provided here. But again, it's optional. So some limitations, also calling out this optional. It's unclear whether the survey was validated in diverse populations, as well as translation on quality and impact of patients' understanding of the discharge instructions if not speaking English. And equity should be focused on the measure, given differences in how patient education can be delivered with that. Before, if there's anything the development wants to say, but anything from the recommendations group, thinking about equity. Again, equity here is, can the measure actually identify disparities in care, which ultimately could help to improve health equity using this measure? Anything from the recommendations group, any additional limitations, anything in addition around this equity domain you'd like to raise? Yeah. Okay, not hearing any. Amy or others from the Yale group, anything you'd like to add on here? We talked a little bit about the different languages already, but is there anything you'd like to add about any future work being done?
Sure. I would just note that equity is very important to YILCOR and a key focus area for CMS, and was really part of our discussion around the decision not to risk adjust this to hold facilities accountable for meeting all patients where they're at and achieving that understanding and tailored discharge instructions.
Okay, great. Thank you. All right, last call for any comments from the recommendations group on equity. Okay, all right, let's go to the last domain here, use and usabilities on the next slide. So for use and usability, there's things the committee should really consider here as well. If it's a new measure or if it's a maintenance measure. If it's a new measure, which is the case here, we want to see either measures currently being used or there's a plan for use. And if there's any additional information the developer has on feedback and the feedback mechanism for the measure. For a maintenance measure, which that's not what this measure is, we do want to see that the measure is being used, especially maybe within an accountability application, as well as there's a feedback mechanism in place, what that feedback helped to do with the measure, if anything at all, things like that. So this is a new measure. And so the staff assessment for this measure was that it was met because there was a plan for use. And you can see the plan for use was in the hospital outpatient quality reporting program, which is an accountability application. There were some limitations that were identified from the committee. It's not sufficiently generalizable. I think this comes back to maybe some of the smaller sample sizes using in testing, as well as unclear how the data would be furnished to providers to help with care. Before maybe I'll ask Amy or her colleagues to speak to maybe some of those limitations. Does the recommendation group have any additional items they'd like to ask here, or any limitations they felt that they had identified for use and usability? Again, if it's being used or planned for use, and also the usability of the measure that can actually be used by providers. Okay, not hearing any. So Amy, I'll turn it to you if you'd like to speak to about maybe how the data can be shared by providers to improve care there.
Absolutely. The beauty of the design of this is that providers administer these surveys and receive the raw results right back, potentially in real time, depending on their vendor agreement. So the ability to see the data, make improvements, iterate, there's no wait like there is for, say, a claims-based measure or some other measures.
All right, any additional follow-up from the recommendations group? Anything that you found concerning? Yeah, okay, so it's good. So again, new measure, there is a plan for it being used. And thanks, Amy, for speaking to some of those limitations as well. I'll confirm once more, Mary Beth, Whitney, anything that we had missed. I also did not hear any conditions being placed on this measure, but please correct me if I'm wrong. But Mary Beth, Whitney, any thoughts from you?
Yeah, this is something that's not really in usability, but when you send out the survey and you don't get a response, do you have follow-ups that encourage response at all? Do? Okay.
Well, so that is an implementation item.
Okay.
We do recommend follow-ups at, I know, 7 days. I don't remember if there's another one.
Okay. All right. Thank you. No other issues.
Okay. Whitney, anything else?
Not at this time, thank you.
Okay. All right. Before we go to vote, Amy or others from your team, any other final comments or points to make before we go to a vote?
I just wanted to thank everyone for the time. Reading through the evaluations, it was clear that a lot of effort went into reviewing this measure and giving it thoughtful consideration, and we appreciate all of the input.
Great, thank you so much. Okay, so let's go to a vote. And again, as we go into this first vote, there was no conditions that the recommendations group had expressed to be placed onto this measure.
All right, let's go ahead and jump in. Welcome back from lunch. Appreciate everyone just taking a quick break there. Again, my name is Nicole Brennan. I'm the Executive Director for Partnership for Quality Measurement, and will be facilitating the next two measures with you today. The first post-lunch measure that we have is CBE ID 4130, and you'll see it has the little e after it, meaning it is an electronic clinical quality measure. This is hospital harm post-operative respiratory failure. This measure is stewarded by American Institutes for Research, or AIR. If representatives from AIR are on the phone and are able to raise their hand and come on camera, we'll know that you are here and can turn things your way as we proceed. Okay, so this measure is a new measure, so it has not previously been reviewed and endorsed by a consensus-based entity. It's an outcome measure for adults 18 years and older. The care setting is for hospital inpatient, and the level of analysis was the facility. AIR described the measure as such. They noted this is an electronic clinical quality measure which assesses the proportion of elective inpatient hospitalizations for patients aged 18 years and older without an obstetrical condition who have a procedure resulting in a post-operative respiratory failure. Let's go ahead and look at some of the comments that came in about this measure. I'll go through the comments and then I will open it up for any additional public comments before we go over to AIR. So we received 6 comments for this measure. You'll kind of see it broken down here across the next 2 slides. One set sort of noted that they felt the measure should, as it is, going through a consensus-based entity for endorsement before being put into implementation. We also had some notes around supporting the measure while encouraging the developer to consider non-elective hospitalizations to improve monitoring. Another comment was supporter of the measure, emphasizing that post-operative respiratory failure is the most prevalent and serious post-op pulmonary complication. Around feasibility, one person noted that they had a concern that the measure, without more information on sort of the specifications of the electronic components in the measure, that they couldn't fully evaluate the measure. And on the next slide, we have a comment around suitability. So it says one comment noted several areas of concern that may make the measure unsuitable for its use, including non-standardized data capture and sensitivity of screening technologies overshadowing performance. I know there were another number of comments from our advisory group members, as well as the recommendation group as you went through your initial evaluations, which the measure developer had a chance to review. So why don't I just give it over to them for a minute to provide like a 5-minute overview of the measure, and then we will, oh, I'm sorry. First, let me open it up for public comment. So is there anybody on the line who wanted to provide a public comment? Okay, I am not hearing any. And do we have our representatives from AIR on the line?
Yes, we do. Dr. Garth Utter will be presenting for us today. Go ahead, Garth.
Oh, great, thank you.
Thanks. So yes, welcome back after lunch. Good afternoon. My name is Garth Utter. I'm from the University of California, Davis. I'm a trauma and emergency general surgeon and surgical intensivist, just for context. So I frequently take care of other surgeons' patients when they need intensive care. I've also been involved with patient safety measure development and support for, gosh, I guess about over 17 years now. And in addition to the current measure, I have quite a bit of experience with AHRQs and CMS's PSI 11 for postoperative respiratory failure. So I'm joined today by my colleagues at the American Institutes for Research. And we would like to thank CMS as the measure steward for their support. So postoperative respiratory failure, let me just call it PRF for simplicity, is commonly defined as unplanned intubation or prolonged mechanical ventilation after an operation. The proposed ECQM is closely modeled after the American College of Surgeons National Surgical Quality Improvement Program, or many of you know this as NSQIP, measures for unplanned intubation and on ventilator greater than 48 hours, two separate measures. In fact, our measure incorporates both of those concepts, and NSQIP has been widely adopted across US hospitals. Our measure is intended to complement and eventually perhaps supplant CMS's PSI 11 measure. So PRF is considered to be really one of the most serious of postoperative respiratory complications because it represents the end stage of several types of pulmonary complications, for example, pneumonia, aspiration, pulmonary edema, ARDS, as well as non-pulmonary complications such as postoperative sepsis, oversedation, seizures, stroke, heart failure, pulmonary embolism, to name a few, fluid overload. So there's really no question that the PRF is associated with high morbidity, longer hospital stays, increased risk of death, higher costs, and more 30-day readmissions. No patient wants this to happen to them if they can possibly avoid it. The incidence of PRF varies by hospital, with higher reported rates in non-teaching hospitals. And generally speaking, published data suggests that there's room for improvement. So this measure is a risk-adjusted outcome ECQM that assesses the proportion of inpatient elective hospitalizations for patients aged 18 years or older who have a procedure and then subsequently develop PRF. We developed and tested this measure using data from electronic health records from 12 hospitals across two different types of electronic systems, Epic and Cerner, with varying bed size, geographic location, and teaching status. Risk-adjusted rates showed substantial variation in scores across the 12 test hospitals, ranging from 0 to almost 17 cases per 1,000 hospitalizations. One facility out of the 12 actually had a risk-adjusted rate that was significantly below the average. The risk model seems to have excellent discrimination with a C-statistic of 0.83 in the holdout test set and 0.91 in the final probit model. Of course, these values indicate strong discrimination performance relative to a random classifier, which would be 0.5. Testing also indicated strong measure reliability and data element validity. So, bottom line, we think that this measure would allow organizations to track the number of PRF cases to try to reduce harm or at least undesirable hardship to patients and compare their performance with that of other organizations. Currently, there are no ECQMs that focus on postoperative respiratory failure, and the available measures are either based on Medicare claims data, for example, PSI 11, or proprietary registry data that not all hospitals participate in, such as the NSQIP or similar Society of Thoracic Surgeons measure. So this ECQM would identify cases from an all-payer population and would not be dependent upon ICD-10 codes, such as with Medicare claims, providing the opportunity for hospitals to assess their rates and for others to compare them in a much larger and more diverse patient population. And eventually, again, paving the way to replace PSI 11 with this measure. So we're grateful for the committee's consideration of the measure. We know, of course, you have some concerns, and we look forward to discussing the measure and answering any questions you have.
Thank you, Garth. That was fantastic. So we're going to go ahead and do our round robin. Rather than sort of calling out people's names, how about you just go ahead and put your hand up, and I will call on you if you have some clarifying questions or overarching comments about the measure, and then we can turn it back over to AIR to help answer those questions. So go ahead and just put your hand up if you have something that you would like to sort of put out there for other members on the committee to hear, or questions for the measure developer. And while you're doing that, maybe I'll go ahead and go to Garth and sort of note, one of the most common, I think, questions that came in was around the definition of PFR, or PRF. If you could think about sort of how and why you structured the definition the way that you did, that might help us get in front of that question. But
yeah,
go ahead.
Thanks for the opportunity to address that, because I know when you look at the specifications, it probably looks just quite confusing and really complex. It's you might liken it to they're not necessarily, they're sort of like a Toyota Corolla. Sorry to the Corolla owners out there. I used to own one myself, but I mean, it's not pretty, but it's very functional, I think, is the sort of the take-home message. So in essence, the criteria are as convoluted as they are because that's what we needed to do to get around some of the issues related to sort of the quality by which hospitals are recording information in their records about particularly the acts of intubation and extubation, as well as details of the mechanical ventilation. And so that's kind of the part of the issue, is I think, as to why there seems to be a problem. So in essence, the measure, we naively might have assumed that we could just go and collect information about intubation and extubation as well as ventilator settings. But what we realized as we got into it was that we really had to account for occasional discrepancies in how that information was recorded, and really use both of those types of information to sort of accurately understand what was going on for a particular patient.
Thank you. Vilma?
Hi, yes. I just had two questions really. One is about the arterial blood gas, trying in terms of the denominator exclusion. You mentioned getting that within 48 hours prior to the procedure, and if it was PaO2 was low, then you would exclude the patient. Same thing with the CO2. But in terms of usability, you'll find that patients with bad COPD, they're not getting ABGs within 48 hours. So I imagine that would cause an undue burden, because you're putting people in a situation now where perhaps they're getting this on the day of surgery, because not all patients with COPD actually go to the pre-anesthesia evaluation clinic. So I'm trying to get an idea of the function, in terms of the usability. How do you imagine that people will get this ABG within 48 hours of the OR? And then the other comment I have is the other thing that, because I applaud the measure, I think is really important, but in terms of the world of anesthesiology, we now have practice guideline on the use of quantitative monitoring of neuromuscular blockers. So that's something that you can add as evidence that proper monitoring of your level of blockade will be helpful in terms of preventing postoperative respiratory failure.
Thank you, Vilma, for that comment. Yeah, that's a good point about the neuromuscular blockade. Regarding the ABGs, so our intent really isn't to exclude or somehow burden, providers who are taking care of patients with bad COPD. Those patients should actually be really kind of included in the denominator, and we believe accounted for in the risk adjustment. The criteria for the ABG results really are more related to weeding out patients who are clearly very sick from a respiratory standpoint, and usually that's an acute problem. And so we think in those cases, it's likely that there would be an ABG, and it wouldn't generally add to resource use or change practices.
Okay, all right, because in terms of the risk factors, people with COPD that may not be acute, but could be chronic and severe, they're the ones who may be missed in this because they're just getting by, they're on their home O2, and they're going to be high risk for respiratory failure post-procedure. So they would probably be seen by their pulmonologist. Usually it's within the month, sometimes 2 months, and you would miss that window potentially in terms of drawing an arterial blood gas. And then you would say, because, they had that whole campaign, choosing wisely, are we doing extra tests just to prove that we don't qualify for this measure? So that's what I was just worried about.
Yeah, maybe I'm not totally understanding, but again, I mean, I think, so COPD is very common, right? And it ranges in severity. I don't know that we would want to exclude all patients with COPD. But to be precise about the denominator exclusions, it combines both the arterial partial pressure of carbon dioxide, but also a pH abnormality. So it generally wouldn't apply for patients who only have COPD, chronic COPD. And generally, patients who have some severe, acute problem, whether it be COPD or some other process that results in a elevated CO2 level, it would also potentially, be associated with an abnormal pH as well. And that's really the intent of the exclusion.
Okay, thanks.
Philma, did you have another question? I know you indicated that maybe you had two.
Well, no, I guess it was the second one was a comment about adding more details about the quantitative monitoring. That's about it.
Okay. Other round robin questions, comments, initial impressions on the measure? Okay, well, let's kind of dive into some of the specifics of what we saw when the measure was reviewed. Go to importance here. And we talked about this first one already a little bit. So you can see that consensus was really not reached around importance, although there was a lot of strengths noting how important this is, and the support of the literature review. So I think, and we talked about this, that there was just lack of consensus on the definition of PRF, and wanting to know sort of how the measure developer decided to come up with theirs. And that came up again sort of in usability. And then another question around, and again, this somewhat usability related, but how what interventions are there if someone is experiencing this, and how can hospitals or clinicians use this information to make a difference?
Right. Would you like me to address those?
Yeah, let's go ahead.
Sure. So like I was explaining, I mean, I think, in general, amongst clinicians, there's little question that this is a significant event when it happens in a patient's course. I mean, we'd be loath not to, update family members with this information when it happens, so on. And so I think it's one of those concepts that, there's so many different pathways by which it can occur. And it's just so obvious to people that as a result, there's just not a lot of like really ideal literature on it in terms of, you know, we know that this risk factor, you know, is this highly associated, or you know, some particular intervention works at preventing it, because everybody knows that, you know, if you oversedate a patient, you know, you have to control their breathing for them, or if you give a fragile 85-year-old who undergoes a pancreatic duodenectomy, you know, and they have bad COPD, and you just willy-nilly give them a whole bunch of IV fluids, that you're going to have a problem. So I guess, you know, that's why we struggled a little bit maybe in presenting that evidence, because it's more along the lines of, it's just widespread kind of common knowledge, rather than specific studies you can cite.
Other thoughts around importance, and this can be in support of the importance of the measure, as well as any additional questions. Go ahead, Kyle.
Yes, so my question was in particular to interventions, because as an EM and critical care-based pharmacist, to me, this seems like a measure with a lot of obvious interventions that could occur based on the reported outcomes. And I saw this as a limitation in the writings of a couple different people, saying that there may be a lack of interventions expected to be able to be implemented. And from my perspective, I thought that this was actually a strength, that there would be very many things, either from a medical, ventilation during surgery, decreased surgical times, that those were pretty clear. And I thought that was a strength of the measure and would actually garner more support.
Yeah, thank you for that comment. I mean, we agree. And it's not that there's no evidence for interventions that help. You know, there's, you know, moderate quality evidence for interventions like, you know, fluid management strategies, use of regional anesthesia, less invasive operation, like a, you know, laparoscopic procedure when that's a possibility. You know, to some extent, even like prehabilitation, like teaching patients sort of pulmonary hygiene techniques preoperatively. So we agree. And you know, one separate issue I should emphasize is that, you know, we really are using, you know, a consensus-based definition, really, as illustrated by, you know, NISQIP's, you know, in essence, same strategy.
David, hi, go ahead.
Thank you. I just wanted to, you know, give some support to Garth so he doesn't feel like the silence is opposition here. As a surgeon, I kind of agree with Garth. A lot of this is certainly prevention of the respiratory failure, you know, by your interventions on a daily basis. You know, there is some concern, you know, that this will drive some patient selection issues, you know, but that may be appropriate, you know, like that we don't necessarily offer surgical and really high-end invasive surgical options to a patient that's going to necessarily or guaranteed to have postoperative respiratory failure. So anyway, I just wanted to give my support, actually.
Thank you.
I'll just briefly comment, if you don't mind. Thanks, Dr. May. Yeah, by no means is this measure intended to suggest that these are never events. I mean, they will happen, just like, you know, other complications, post-op sepsis and so on. But yes, the idea is to try to stimulate ourselves to do what we can to minimize their occurrence.
Any other comments around the importance of this measure? Okay, let's take a look at feasibility. Here you can see we had a strong number of people noting that they felt like feasibility was met. 89% of those who submitted initial reviews One person noted, in testing, there were some inconsistencies in mechanical ventilation documentation, where in some centers, unstructured fields were being used to capture MV initiation and conclusion. So that was sort of one of the limitations that was noted, but a lot of strengths just sort of saying there were no significant barriers noted, and that nearly all the data could be captured in the structured fields. So maybe can you talk a little bit about those unstructured fields and how you would work those in as it was implemented?
Right. So like I was alluding to, I mean, I think when we first set out to design the specifications for this measure, we looked at, medical records and thought, well, gosh, we just, in essence, collect the time of intubation, the time of extubation, and then the timing and nature of ventilator settings. So that generally worked okay, but we found that some centers, occasionally would have errant information, like for totally unexplainable reasons, there would be like a mechanical ventilation setting, when a patient was not on mechanical ventilation, maybe it was mischarted, or the alternative, a patient was on a ventilator and somebody erroneously in addition, we found that some of the times we thought, an intubation of interest was occurring, it was actually just an issue of a patient was intubated before having like a endoscopy or MRI study or something. So we basically incorporated information about where the intubation was occurring, specifically a procedure area, to address that concern. So we appreciate the reviewers' concerns, but this was really an issue that we tackled during the measured, development process, and we think we've really pretty successfully addressed it, actually.
Other comments here. I think, and just, tying the pieces together, this does kind of come up again in the usability, but maybe it is around feasibility, Garth, is that, so if those structured fields don't necessarily currently exist, is there a case that promoting more structured fields, that the burden of that is outweighed by the potential benefit of this measure?
Yeah, I mean, thank you for bringing that point, because it's a really good one. I mean, this is information that hospitals really should be capturing. I mean, it's pretty fundamental to care that's provided, and so to us, it makes sense that maybe the indicator will help kind of standardize and improve the quality of this information in hospitals' electronic records.
Hi, this is Mia from AIR. I just wanted to add some additional context. So I just wanted to clarify that the feasibility issues were not related to the structured fields not being in existence. At all test sites, mechanical ventilation, intubation, and extubation was all available in electronic structured format for data reporting, but it was clinical workflow variation and how the systems utilize those fields that was not to say an issue, but where there was an opportunity to improve the standardization among workflows and how and what they're capturing in those flow sheets. So I just wanted to add that context in there, that from a technical reporting standpoint, that's a non-issue. It was more clinical workflows that we were seeing opportunities for improvement and standardization.
Excellent. Thanks, Mia. Mary Beth or Whitney, anything that I've missed so far as we're working our way through this?
I hadn't seen anything, Nicole, so I think you covered everything that I pulled out. So thank you.
Yeah, fantastic.
Likewise, thank you, Nicole.
Yeah. Okay, let's take a look at the next slide. Here we had 100% people note that they felt like scientific acceptability and reliability was met. There were just a couple, I mean, sort of pulling out from your own data around that, this was done in 13 hospitals, one only within collecting through alpha testing, a note around 11 using Epic, and a number of hospitals coming from the same system. Somebody did note in there that they thought all hospitals were in urban areas, although there was quite a range of number of patients per hospital. So some hospitals were as low as 100 upwards. I don't know if you have any sort of comments around, urban versus rural for this measure, if you feel like that was captured within the size of the hospitals themselves or the makeup of the hospitals that you chose.
So Mia, do you want to maybe comment about that?
Sure. So in terms of rural, I could say that, we had a lot of hospitals that fell into that less than 200 bed situation. So we did test the measure in smaller hospitals. I would not be able to say rural is an accurate description, but we did have a good spread between large academic settings, community teaching hospitals, and small hospitals that were in the 100 bed range.
Fantastic. Okay. Next slide. And everyone feel free to raise your hand at any point. I don't want to rush us through this measure if you have questions or concerns. There was just a lot of support for this one across the board. So here in equity, again, you can see that it was noted this was 100% met. You guys really put in a lot of information around equity and noting that there are disparities in health outcomes, that you felt like this measure would help promote equitable health outcomes if it were in place. Is there anything else you would like to say about that, or say about sort of data collection to moving forward that will help us know more about health equity for this particular issue?
I don't have much to add on that issue, no.
Okay. Okay. Let's look at our last slide here. All right, so we have 89% noting that this was met. Questions about usability, use and usability from the committee members. I think we talked quite a bit about this earlier, but one of the limitations was concern about the measure's use in payment models, and evidence cited showing that reduction of PRF is challenged by unclear evidence regarding risk factors and application of interventions. So yeah, thoughts on that. I know that we heard that we felt like there were a lot of recommendations or things that could be done, and maybe that's just one of the things that could be released with the measure, is just more citations on how you deal with it if this is something that occurs. Other questions from the committee members? Mary Beth Whitney, anything here? Nope.
Not for me. Thank you.
No, thank you, Nicole.
Okay, so not a lot from the committee on this one. And as you can see, we had a lot of consensus across the board with the various elements for the measure. And we talked a bit about the importance as well as the definition that was used for the measure, which was the main sort of limitation noted in importance. With that, if Mary Beth and Whitney are feeling comfortable, we could just go ahead and move towards our vote. While we get that set up, Garth, any sort of closing comments around sort of this measure and sort of the need for this right now?
Well, I think I mostly addressed that, just again, to emphasize the point that I think the key advantage of this is that this indicator does not have a lot of the limitations of PSI 11, which is kind of rigid in terms of the available procedure codes for the duration of mechanical ventilation, and it doesn't capture certain things like, reintubation in the PACU, for example, because of some of those timing issues. Furthermore, it's not dependent at all on merely a physician diagnosing respiratory failure. We realized that was, kind of a quite subjective thing. And yet, it doesn't have the limitations of hospitals having to, sort of enroll to participate, like with NSQIP. The only other issue maybe to just address briefly is I know that there were a few concerns kind of on the sort of the use topic about like unintended consequences. There is possibly a concern about patient selection, but we think that ultimately, surgeons are guided by, their strong ethic to do right by patients, and if a patient really needs an operation, to provide it or refer them to somebody else who will, have the expertise to perform it. As far as tracheostomies, I think maybe that issue came up in some of the comments. We're not really sure how that would be much of an issue, because generally those patients would be, if a tracheostomy is performed, almost always that's after respiratory failure. We imagine it'd be very unusual for patients to basically be subjected to a tracheostomy during the initial operation, as a way to avoid this measure, especially for elective operations. One final point on non-invasive ventilation. It is possible that this could promote more use of non-invasive ventilation. I think, at least for some operations, non-invasive ventilation is probably contraindicated, and in some patients. So it's something we'll have to follow and monitor. On the other hand, I mean, it could be argued that maybe patients actually prefer it, and if it's not unsafe, maybe it should be, kind of a desired outcome of the measure to increase its use. My personal experience is that generally, when non-invasive ventilation is inappropriate, the way that the patients fail is they get intubated and put on the ventilator for a prolonged period. So I don't really see it as being a terribly concerning problem. And I've kind of prattled on quite a bit, so maybe I'll just stop there.
I will say that we did get one comment from one of our advisory group members who's a patient who felt like this was very important from the patient perspective. So thank you, Rosie, for putting that forward. So with that, let's go ahead and move into our next measure. We have measure 4120E. Again, the E stands for Electronic Clinical Quality Measure. This again is a measure developed by AIR and is a new measure, meaning it has not been endorsed yet by a consensus-based entity. It's an outcome measure for patients 18 years and older, similar to the previous measure, hospital inpatient and facility level. And this measure was described as the ratio. This ratio measure assesses the number of inpatient hospitalizations where at least one fall with a major or moderate injury occurs among the total qualifying inpatient hospital days for patients aged 18 years and older. So what I'm going to do now is kind of look through the public comments that came in. We'll open it up for any additional comments and then allow AIR a chance to provide sort of a background on the measure. So you can see here that 11 comments came in during the public comment period. Notes 3 comments supported the measure, and one of the comments encouraged the developer to potentially clarify the denominator exclusion language And another comment supported the measure with the condition that it receives endorsement, which is the purpose of today. There was a note around unintended consequences. So 4 comments raised concern that this measure may lead to the reduction of mobilization for patients in order to reduce fall numbers. Concern with measures injury classification. So 4 comments raised concern with the classification categories for injury used in this measure. And next slide. And then we had 2 comments that emphasized the challenges associated with electronic clinical quality measures, or ECQMs, and the implementation and burden of that. I know we talked about that just briefly before. We can circle around back to that during this discussion. I'm going to go ahead now and open it up to any additional public comments. Do we have anybody on the line who would like to add a public comment related to this measure? If so, please raise your hand now. Okay, I'm not hearing any. I will turn things over to AIR.
Good morning from the West Coast, or good afternoon. Can you hear me?
We are getting a bit of an echo from you.
Okay, I'll fix that.
Now you're completely muted.
Now.
You are perfect now.
All right, can you hear me well?
Yeah, you're great.
Okay, thank you. Good morning from the West Coast. Good afternoon on the East Coast. I'm Dr. Patrick Romano. I'm a professor of general internal medicine and general pediatrics at the University of California, Davis Health in Sacramento. I've worked for over 30 years in this space, developing, refining, and validating healthcare quality measures. And I'm honored and privileged here to represent the next 2 measures on behalf of our team. I'm joined by my colleagues from UC Davis, our analytic and risk adjustment lead, Dr. Monica Ray, as well as our nursing quality improvement lead, Irina Tokareva. I'm also joined by my colleagues at the American Institutes for Research. You've already met Mia Nivera, our ECQM lead, and Shanna West is our validation lead. So we're pleased to present this ECQM 4120E, hospital harms fall with injury. And of course, CMS is the measure steward who supported our work on this. So I think we all recognize that inpatient falls are one of the most common and distressing incidents that occur in hospitals. They increase length of stay, they increase costs, they cause discomfort, they cause extended recovery for patients. It's a significant problem, estimated between 700,000 and 1 million inpatient falls annually. About 1/3 of those resulting in injury. These falls, by the way, are monitored as part of AHRQ's program with patient safety organizations. Up to 11,000 of these falls may result in death. We also know that there's variation, both from prior literature, from the work of the National Database of Nursing Quality Indicators, as well as from our own testing work. We see that there is variation across facilities. And we also know from extensive systematic reviews and clinical practice guidelines that there are specific things that hospitals can do to prevent falls with injury, including fall risk assessment to gauge patient risk, implementing fall prevention protocols, addressing risk factors, environmental rounds, and really encouraging supervised mobility. So this is an ECQM. The numerator is the denominator consists of inpatient hospitalizations. The numerator consists of the subset of those inpatient hospitalizations with at least one fall with a major or moderate injury. This is an all-payer measure. that includes all adults age 18 and older, with some very limited exclusions. The definitions for major injuries basically include things like fractures, closed head injuries, internal bleeding. Moderate injuries include things like lacerations, open wounds, dislocations, sprains and strains that require medical attention. And we've aligned these definitions as best we can with the National Database of Nursing Quality Indicators definitions. We developed and tested the measure using EHRs from 12 hospitals, 2 different systems with variation in bed size, geographic location, and teaching status. We did confirm substantial variation. We developed a risk adjustment model to account for some basic factors, particularly neurologic factors that are associated with increased risk of falling. And we demonstrated a good performance for that model with a C-statistic of 0.78 in the 0.78. And we confirmed through testing strong reliability and validity on all metrics. So I just want to briefly address 2 themes that came up in the reviews. First, there were some concerns about whether this should be risk adjusted or not. And I want to emphasize that we really discussed this extensively with our technical expert panel, reviewed the literature. I think it's pretty clear that there's nothing that works 100% of the time to prevent falls, that there are some patients who are just at higher risk than others. So for a measure that's going to be in this accountability space where hospitals are going to be compared with each other, we want to create a level playing field that allows hospitals to be compared when they have very different patient populations. There is nothing about risk adjustment that excuses or writes off falls that occur in any patient, whether they're a low-risk patient or a high-risk patient. Every fall gets counted, and every fall penalizes the hospital in effect. So the purpose of risk adjustment really just to level the playing field. Also, I want to address this point about mobilization. When you look at the literature, you look at all the systematic reviews, clinical studies have been done. There's just no evidence that the way to prevent falls in hospitalized patients is to restrict their mobility. That's not how you do it. It doesn't work. When you try to restrict patients' mobility, they still try to get up and they fall. So the things that we do to prevent falls with injury is not to restrict mobility, but to address risk factors, to address our medications, to provide nursing supervision, physical therapy, and to mobilize patients in a careful and responsible way. So I'm just addressing those 2 issues. Really, we're very pleased about how this measure has turned out. We think it'll provide a powerful tool for hospitals to track and trend their fall rates over time and against benchmarks against each other. And ultimately, the plan, again, is for this measure to replace the claims-based measure PSI 8 that is currently part of the patient safety composite PSI 90. So I'll stop there and look forward to further discussion.
Great, thank you very much. Start our round robin. If anybody has overarching questions or thoughts about the measure, including its importance, yeah, feel free to go ahead and raise your hand now. Okay, let's go ahead and start looking at sort of the specifics. I can go ahead and note that in the staff assessment, each element was marked as met, and the committee generally agreed with that assessment. So we can look here and under importance, 95% of those who returned evaluations felt like the measure was very important, that was very well laid out, that it filled a performance gap and a gap within data collection. The only limitation really noted was the measure information forms importance section should be updated to document screening and mitigation strategies described elsewhere in the submissions. So it wasn't that that information was missing overall, it was just a comment about the fact that those things also play into the importance of the measure. Any additional comments around the importance of this falls measure? Anything, Mary Beth or Whitney, from the patient's perspective on the importance of a fall measure?
No, I don't have anything to add. This is a very important measure. So yeah, I think it's right on actually. So thank you.
Yeah, similarly, the comments are just consistently, this needs to happen. Thank you for doing such a great job assessing it, et cetera, et cetera.
Thank you. Let's take a look at the next element. So we have feasibility here. 90% felt like it was met, only 5% felt like it was not met but was addressable. Nobody thought that it was not met. So here the strengths were around only one hospital required a workflow change, and all data elements existed in the structured fields and EHR systems. Limitations noted or information about falls may reside in text fields, and feasibility testing did not include hospitals using other significant EHR systems like Cerner or Meditech. Patrick, do you want to comment at all about, feasibility for other types of EHR systems based off of what you've seen so far?
I will defer that to Mia.
Good afternoon again. So no, I don't have any issues with feasibility of this measure. We did construct it to support EHRs that did not or are not able to capture fall documentation in structured fields. So there are two pathways to get into the numerator, so to speak, and that is based on either a falls documentation during the encounter or a falls ICD-10 code. So hospitals that do not have structured documentation for falls can utilize the typical ICD-10 encounter data that would be reported for the PSI measure of any sort. So we built that in for that specific reason, is to have a broad ability to report on this measure.
Amber.
Thank you. I just had a question, or if you could provide some clarification on those facilities, maybe small and rural hospitals that they screen for falls, but if a patient falls and has a injury, it may not fall onto the claim because it's not coded. Do you have any thoughts or suggestions on how to close that gap?
Yeah.
So one of the things with falls is that there's typically not a connection between the coding system of whether the injury is related to the code or not. And so one of the ways that we worked on that is that patients who fell that had a present on admission fall, they were removed from the system, from the measure, from the denominator population, to eliminate some of the relationships between whether that injury was related to a fall or not. In terms of improving, I think that's a basis on, it's not necessarily related to the claims per se, it's based on documentation of the encounter data that's listed in the tables for ECQM reporting. So it's not solely reliant on the claim, it's on the final coding for ICD-10 that's captured in the encounter data for electronic health record reporting. Does that help to answer your question?
Yes, thank you.
Additionally, hi, this is Shanna. Additionally, with the measure, we're looking at moderate or major injuries. So those injuries you would see, for example, if the patient fell and an orbital fracture or a laceration requiring suturing or things like that. So you're not necessarily going to see just, okay, the patient fell and they have a bruise. Those things you wouldn't see coded, but the types of things that are being used in this measure, you would see coded. So I think that kind of makes that difference. We're not looking at those more minor injuries, we're looking at those moderate or major injuries.
And I should have introduced Shanna West as our validation lead, so thank you, Shanna.
Thank you. I wanted to make sure that we noted from one of our patients on the advisory group member or on advisory group committee, Rosie said, as an amputee, this measure is extremely important to me. One fall could cause me to become more or completely disabled and require me to enter a long-term care facility. So I think that's really important to acknowledge the patient perspective. Whitney, do you want to add anything else around sort of why measures like this are important to patients?
I think Rosie said it perfectly. At the end of the day, the complicating factor isn't a hospital's quality standing, but individual patients risk tremendous amounts of complications and life-altering impacts. I appreciated Dr. Romano's comment about, the solution to preventing falls isn't to keep a person bedridden. It's actually, to achieve health, which is what we always want to do, right? As healthy as possible. We've got to start thinking more broadly and looking at the problem from where it starts, and providing patients like Rosie the opportunity to have as much success as possible in any procedure with as limited risk.
Thanks, Whitney. Let's take a look at the next question or the next element. Scientific acceptability, 89% met, 11% not met, but addressable. Strengths noting reliability analysis approach is appropriate and findings meet the threshold for reliability. The measure has strong face validity and numerator and denominator elements have excellent positive predictive value. Some of the limitations. So sample use for reliability testing was small and sample is not representative. It includes only large teaching hospitals. Smaller rural and non-teaching hospitals are not included. So let me turn this back over to the measure developer to discuss the hospitals that were selected and how they are represented.
So again, as in the 12 hospitals, we did have a big spread in terms of urbanicity around the geographic location, from large academic settings to community hospitals, and then beds under that 100 mark. So in respects to rural, that wasn't exactly reflective, but it is feasible in anywhere that you could report ICD-10 codes. So again, that's why in terms of the use of the measure and the feasibility of the measure, there isn't any concerns in type of what type of of hospitals that this measure could be implemented in, as we did open up the window for the use of ICD-10 coding. And that's in just response to Ms. Rosie Barchel's comments there that we are not looking to leave rural hospitals behind. This is absolutely valid for that population. It's just a matter of ECQM testing. Sometimes those hospitals are not able to participate in this type of work, but we did ensure to try to get smaller bed hospitals so that we could have some representation of smaller, less than 100, the 100 bed range.
So to kind of summarize that, would you say one of the bigger challenges on this is some ECR rural hospitals just don't have the same level of electronic health record access as the bigger hospitals? Is that what you're saying, sort of from a testing challenge?
No, they utilize these same EHR systems. It's more of time and exposure to be able to participate, being that they're smaller hospitals, lesser resources to commit to testing measures, more so than feasibility of the measures.
So as we move forward with the measure, we can kind of keep an eye on how rural hospitals perform on the measure and make any adjustments through that way of monitoring the measure over time is what I hear you saying also. Yep. Okay.
Yeah, I'll just emphasize, for those of you who've done this work, it's quite labor intensive, right? Because we really have to partner with the test sites to be able to go in and validate their records, their actual text records. And so this requires that the test site has to have personnel who can take that time to work with us. So it's really not an issue of the feasibility of the measure, it's the feasibility of participating in testing.
Is anything happening on a broader scale to expand services to the smaller rural hospitals and non-teaching hospitals, separate of this measure, obviously, but just with your knowledge, I think that would help support some future conversations.
Thank you for that comment. I'm just going to chime in and address that. We offer several services to offset, resources for sites to be able to participate so that we could support rural hospitals with lower staff. And it's just a matter of the people it's not a matter of them not wanting to participate. It's the powers that be to decide whether or not they can. So from a measure developer perspective, we provide every opportunity and support so that they are able to participate in some of the services that we offer to actually collect, map, implement the data to support them. But I think, this is a global issue in terms of electronic health record, ECQM testing that, one measure developer is not going to be able to resolve it. It'll have to be a community approach.
Awesome, thank you.
Let's take a look at the next slide. So this was around equity, and as Matt noted, this was one of our optional categories this year, but something really important and that we're trying to keep our eye on. Strengths noted are social disparity analysis evaluated differences by race and ethnicity and insurance status to determine appropriate approach to stratification. Limitations were sample included only urban hospitals, so evaluation of disparities may be limited. I know Dr. Romano talked about this a bit in his initial introduction of the measure around risk adjustment and why or why not that is appropriate for this fall's measure. And as we also kind of noted, as this measure hasn't yet been endorsed, it's a new measure. Some of these things we will be watching over time if it is implemented in a program or as it gets out into the field. But do want to offer Mia or Patrick any additional opportunities to comment on anything around equity?
Yeah, let me just explain a little bit more because it's a little obtuse how this works. But obviously, when we're looking at falls with injury, there's there are two stages to that, right? First, the patient falls. So there are risk factors for falling, and then the patient sustains an injury resulting from the fall. So there's the risk of injury given a fall. And those two things put together sort of represent this measure. So one of the things that we know from population health, from epidemiologic studies, is that there are, on average, racial ethnic differences in bone mineral density across different racial and ethnic groups. And so specifically in the population that is of Caucasian ancestry or East Asian ancestry in particular, bone mineral density tends to be a bit lower than among patients who are of African American ancestry. So that sort of flows through what we see in the data in that it's pretty well established, for example, that hip fracture rates in the population are a little bit lower for African Americans than for whites and Asian Americans. And we see that in our own data as well within the hospitals. So in effect, what this means is that this measure slightly favors hospitals that have a predominantly African American population. They will tend to have a little bit lower rates than hospitals that have a predominantly Caucasian population. And we weighed different options as to what to do with that. We think that it would be nice to have a reliable metric of bone mineral density in every patient, but of course, that test is not routinely done, nor should it be routinely done in everyone. So we can't really adjust for the underlying physiologic parameter of interest. And of course, it's been well established now that we don't want to be adjusting for race as a proxy for underlying physiologic factors. So, so in this case, we think that this tendency, if you will, for favoring hospitals that have a predominantly African-American population is acceptable in the overall context of how the measure will be used and the other measures that are in the CMS portfolio.
Thank you, Dr. Romano. We can move on to usability, and please feel free to raise your hand if you have any questions or concerns. So strengths here, measures planned for public reporting. There exist evidence-based protocols for falls prevention hospitals can use to improve. Only limitation noted was that public comment called attention to potential unintended consequence of decreased patient mobilization, which I know Dr. Romano mentioned at the very beginning, noting that there's not evidence to show that that's actually happening, although that is certainly some unintended consequence that can be watched for over time. But the literature strongly encourages mobilization to occur in order to prevent falls from happening. Other questions or items that we want to address?
Nicole Florence had a comment in the Q&A that I want to bring to the group, asking if there were complications from a fall that worsen over time, from mild to more serious. Is that scale reflected in this measure?
Yes, so I'll say that what we often see is that the consequences of the fall are not fully recognized initially. So for example, the hospital may just put the patient back into bed and not pursue imaging. And then the patient is continuing to complain of pain the next day, and eventually they get imaging and the fracture or dislocation is diagnosed. So this we are able to capture because we can identify at any time during the hospitalization the injury that was diagnosed and tied to the previous fall. What we would miss potentially is if the injury wasn't captured at all, you know, if the patient wasn't examined essentially and they were just put back into bed and nobody really looked at their skin, nobody did imaging if they were complaining of joint pain, that could potentially be missed, but we didn't really find that occurrence in our validation effort.
Bill, turning it to you.
Oh, okay. Hello?
Yeah.
Oh, sorry. Okay, yes. Yeah, I just wanted to I know we went through this section already in terms of validity, but can we go back to it 1 second? And I just wanted to get more information regarding the sensitivity and specificity and
Sure. So switching back to the scientific acceptability slide.
Right, could you do that? Yes.
Yeah, right there. Yep, go ahead.
Because I saw the positive predictive values, but you know, I just couldn't get my link to work to get to the table. So could you go over those, the kappa statistics, things like that?
Sure. So across all sites, we found 519 events according to the clinical abstraction, 521 based on the measure. So there was a discrepancy essentially of 2 events, and that led to the PPV, positive predictive value of 99.5%. And sensitivity of 100%.
Okay, and
I'm sorry. So that's with the denominator population, and for the numerator, the corresponding numbers were 87 that were found confirmed on abstraction, 94 based on the electronic health record. So that led to a positive predictive value estimate of 98.8% for the numerator, and a sensitivity estimate of 88%. So there were a few events that were missed.
Okay. All right. Thank you. Thank you. Thank you. So this was pretty good, especially in terms of specificity also. Was it, were the numbers so just as...
Yeah, the specificity of the numerator, 99.77%.
Okay, thank you.
Thanks for driving our attention back to that. Appreciate it. Any other questions, overarching comments, anything that I missed as we went through? Mary Beth, I'm seeing a head shake from you. I don't think we missed anything that came in from advisory. Would you agree?
Yes, I agree. I was just going to double check, but yeah, I think we got everything.
Sounds good.
Thank you.
Yeah, Whitney, I think we heard strongly from our patient perspectives that preventing falls, assessing falls, holding hospitals accountable for falls is incredibly important and potentially even life-saving, and changes our abilities to even stay within our own homes, and that this is very important from a patient perspective. Is there anything else you'd like to add to that?
No, I was double checking the submitted comments, and that covers it. The consensus on wanting this to come to life is very strong. Nicole, I'm noting in the Q&A, Tariq is having a hurdle with the hand raise iconography.
Okay, hold just 1 second. Let me check in.
I'll just add while that's being addressed that this has really been the culmination of a 5-year effort. And it was alluded to earlier that Yale started developing this measure 5 years ago. And we really found that we had to address the issues of the sensitivity and specificity by looking at both the nursing documentation, the structured nursing documentation, as well as the physician diagnoses. And so through this kind of architecture, we were able to achieve the measure that you see today. So it's been a long effort. Thank you.
Thank you, Dr. Amana. I think we are probably pretty set to go to the vote. Go ahead and move in that direction.
And it looks like Matt is also trying to help. Eric had a question about sensitivity. I'm not sure if Eric is able to mobilize the microphone or not.
Eric, if you just want to put your question about sensitivity into the Q&A.
You might be wondering about the false negative cases, and I'll ask Mia and Shanna if they can be prepared to discuss that.
It looks like you are absolutely correct.
Okay, so we noticed several different things. One one of the numbers is related to ADT issues, so admission, discharge, transfer issues. So there were encounters that we received the data on them, but upon looking at the records, sometimes encounters, providers will go back and forth with whether or not they want to admit the patient to inpatient status, if they want to put them into observation status. And so when they go back and forth several times, sometimes you aren't able to clearly capture that in the data. So we had some encounters that were not truly inpatient discharges. So that was part of the discrepancy. One of the other discrepancies that we saw was related to coding issues. So there were injuries that were documented, coded as being hospital acquired when the injury was actually an injury that the patient came into the hospital with. So that was miscoded. And then there were a couple of instances also where we looked at the injury, and similar to what Dr. Romano said, that the injury may not have been documented directly at that time of the, of the fall. So directly attributing it to the fall was a bit more challenging. With coding is usually done after the effect, where a patient has been fully discharged from the hospital, and so they'll go through and examine all of the information that's in the record and then try to piece together the events and to determine whether it happened during the hospital or not during the hospital prior to arrival. So that's where we saw some discrepancies as well.
Yep, this is me. I just wanted to add an additional context with the present on admission indicator. I think this was like the biggest coding issue, is whether or not the injury or the fall actually occurred during the encounter. And that present on admission indicator, although the diagnosis code itself was valid, the indication of whether it was present or not was not. And that's where we see some discrepancies based on the documentation and what the coders were actually looking at and determining if it was present on admission or not.
Great, thank you. I do see another question about what will this measure mean on hospitals to report? So maybe they're looking for, is there any burden associated with reporting, and is that burden overweighed by the benefit of the measure?
I can start this off, Dr. Romano, and you can chime in, of course. So in any sort of ECQM, there is a level of effort to implement an electronic measure, but the sole purpose of an ECQM, one of the purposes, is to decrease clinician burden. So the intent of moving this measure from a claims-based measure to an electronic ECQM, we're also looking at real-time documentation, but decreasing the amount of on the clinical side, not necessarily increasing burden from that perspective. So that is one of the benefits of an ECQM. But as with any ECQM, there is some level of effort to implement a measure, but once that measure is implemented, it goes through minor updates on an annual basis, and that would be in the same effort as the other program measures for ECQMs. There's not an additional level of burden. The data structures that we're utilizing are, feasible, so there wouldn't be any additional burden from that perspective. Dr. Romano, do you have anything else to add to that?
I agree.
Fantastic. Thanks, Mia. All right, if Mary Beth and Whitney are comfortable that we've kind of addressed the overarching questions and themes, we can move to a vote. Yeah.
Yeah, I think so. I think that was pretty thorough, and I appreciate the information that that you all have provided. Thank you, Dr. Romano.
So in summary, as Elena's pulling this up, I think that, we heard overwhelming support from the patient perspective for this measure, and across the board, there was a lot of agreement that each of the elements were met. I did not hear any real conditions to be placed on this measure in order for it to move forward for endorsement. So let me turn things over to Elena, and we will open up this measure for a vote.
Yeah, and actually, sorry, Nicole, we were trying to see, connect with Tariq, who just dropped in something into the chat just to see if there's some clarification on a couple things before going to voting. Just mentioning a little bit more clarification and asking, is it fair to assume that based on pressure presented by this measure that hospitals will not limit mobility? And is that a fair conclusion based on the reviews? And perhaps I misunderstood Dr. Romano's initial comment on the reviews, the fact that indicate that the hospitals are not likely to reduce mobility and they tend to reduce falls. So I don't know if the developer wanted to comment on that briefly.
Is that open for our response?
Yes.
Yeah. Yeah. Again, I think we want to emphasize that we invite anyone to look at the literature with us. We've extensively reviewed and summarized literature. There simply is no evidence that restricting mobility is the way for hospitals to reduce falls. It seems intuitive, like if you keep patients in bed and prohibit them from leaving the bed, maybe they won't fall. But any of us who's taking care of patients in hospitals know that patients have ways of wriggling out of the side rails and so forth, and they will fall. And so really the literature says that what we do to prevent falls is to address risk factors before surgery, to address medications, to address nursing care, to provide physical therapy services, really to incorporate early mobility with range of motion exercises and so forth, and to encourage family members and staff to spend more time at the bedside. These are the things that we do to prevent falls.
Thanks, Dr. Romano. And, I'll also note for the committee members, this measure is going through for the first time for endorsement. Should it achieve endorsement, it comes through back for a maintenance review. And at that point, all measures are also asked to assess any unintended consequences of the measure. So the measure developer would look to see if there had been any unintended consequences, such as the ones mentioned here. And we report on that during their maintenance reviews. So that is something that definitely comes up during our maintenance cycles. And I think that the developer AIR has certainly heard that as a potential interest of the committee, and I'm sure we'll keep an eye on it.
I think Dr. Joseph had another question.
Yes, I really like this measure so much, and the foundation of it is using electronic health records. What do you think about the evolution in terms of when will everyone get an electronic health record? I mean, I'm curious in terms of the uptake. I mean, we're trying to move to the next generation, but to the next level, and this is a perfect example of a great measure. And how do you see the future with this?
Well, others can comment, but I will say that this is an inpatient measure. And so, over 95% of American hospitals now have a fully functional electronic health record, partially as a result of the subsidies that were received under the HITECH Act. So I think that there are a small number of rural hospitals very small hospitals that may not have an electronic health record, but that's a tiny, tiny portion of the total market. I think the challenge going forward will be bringing it into other settings like ambulatory settings, skilled nursing, and so forth. But Mia, do you have anything else to add on that?
Nope.
Okay, because we're just seeing it in the world of the perioperative setting and anesthesiology. Not everyone has electronic health records. People are still on paper. unfortunately. So
Yeah, that's an interesting issue, and I think it does relate in part to how anesthesia flow sheets and anesthesia information is sometimes not incorporated into the electronic health record. And we discovered that in the previous measure for postoperative respiratory failure. So we had to develop workarounds in the measure specification to accommodate that variation. But the hospitals still have the electronic health record. It's just they're choosing not to bring in certain information, such as the anesthesia flow sheets.
okay. All right, thanks.
I'll just add a comment to that as well from working with rural hospitals and adopting these ECQMs. A lot of times they do have the electronic health records, but to add the workflow, it's an additional cost because they have to implement something that's not built into their EMR. So I think it's important that we note that we need to hold our EMRs accountable as well and not have that extra financial burden for our hospitals.
Exactly.
Thanks, Amber. And I think, we have a little bit of time at the end of the day today to discuss some of our global issues. And I certainly hear this as something that's coming up just around EHRs and their, the need to continue to support all hospitals having access to those types of technologies. I'm just looking real quick through the questions. Given the high number in the denominator and under-reporting of falls in the hospitals, it may be beneficial to have the denominator be 100 per 1,000 inpatient hospitalizations. For example, the Joint Commission has 611 total sentinel events in 2022 in the US. I don't know if you want to discuss sort of how you chose what you thought the range should be.
That's just a constant. So it could easily be reported in a different way with a different constant.
So I will add this measure as a ratio measure. So we are looking at number of falls per inpatient days. And so it is at that times number of falls times 1,000 to get that rate.
Fantastic. Very helpful. Okay. So Tariq, I do see your question about sort of incentives in place. I think that's a question that kind of comes up more as this would be integrated into a value-based program versus kind of the nuances of the measure itself, and noting if it's sort of a safe and scientifically sound measure. But I will give Dr. Romano a chance to say any final words on the measure before we turn it over to the vote.
Yeah, I see a couple of the Q&As, and so let me see if I can address a couple of those points. So one point, of course, is that we can't anticipate every possible human response to measurement. I think what we're trying to emphasize is that limiting patient mobility would not be a rational response to this measure. And in addition, I'd like to point out that there are balancing measures in the CMS measure portfolio. For example, if you do restrict mobility and keep patients from getting out of bed, you'll probably get more pressure injuries. And so we have an ECQM for pressure injuries, and of course we have PSI-3 as a claims-based measure. Similarly, in a postoperative setting, you're likely to get more venous thromboembolism. So we have PSI-12 as a claims-based measure of postoperative venous thromboembolism. And we have an electronic clinical quality measure that is currently under development that we hope to bring to this group next year. So, so we have balancing measures, I think, to address some of those concerns as well. I think that Larry, Dr. Glantz, raised a question about the uptake of ECQM measures in general and the associated IT burden. Not sure that that is inherent to this evaluation today. Nicole, did you want to discuss that or not?
Yeah, I mean, like I was saying, I think that that might be a good discussion for the end of the day if we have some time to, because it's a really important point, right? Like ECQMs and how we can encourage their uptake or how we can reduce the burden of using them in comparison, like you were saying, to the PSI measures. What I heard you say earlier too is there's a long-term hope that this might take place of the PSI measure, but that's certainly not the in the short term that we would just be swapping the two out. But that there is a need in the community to help build the infrastructure for all hospitals to be able to have access to these technologies and it not to be a large burden to them.
Yeah, I'll also say in response to Dr. Wagner's question that that yes, that all of the standard EHR products have structured fields to capture nursing documentation of certain events like falls, but it doesn't necessarily mean that all hospitals actually use those fields, right? So the fact that the vendors make those fields available, the uptake may vary across hospitals. One of the things that we hope with the ECQM movement, if you will, is that it will, over time, of course, encourage hospitals to utilize the resources that exist in the electronic health record to facilitate this kind of tracking and measurement, which serves both internal and external purposes. I don't know, Mia or Shanna, did you want to say anything further either on that point or anything else that's been raised in the Q&A?
Not in particular. I know that there have been questions about falls that occur in the ED. And so this measure will only look at the ED if the patient is then admitted to inpatient hospitalization. Anything else would be outside of the purview of this measure because this is intended for inpatient hospitalizations. And so including it in different populations would require additional testing or CMS direction on that intent.
So one implication of that is that if the patient falls in the ED and has a significant injury, they're likely to get admitted for that injury, even if they wouldn't otherwise have been admitted. So it brings them into the measure. Whereas if there's no injury, the patient falls in the ED, but there's no injury, then it's less likely to affect the management of the patient in the ED, and they're more likely to be discharged to home.
Thank you for that nuance. I think that's really helpful. And certainly, Amy, what I'm taking away from your comment too is an interest in seeing potentially a future measure that looks specifically at falls in the ED, which might not be covered here in this measure unless the person was transferred to be an inpatient, but that you feel like there's a need to have a better eye on falls in the emergency departments. Okay. And then a last note, because I think I called for move to the vote like 4 times now, but we've gotten such great questions. But Rosie did say the more data on the hospital has about falls can only improve patient outcomes. All right, Elena, turning it over to you.
Okay, I am going to go ahead and open the vote here. Bear with me. Okay, voting is now open for CBE number 4120E, hospital harm falls with injury. Based on the evaluation of this measure, please indicate your endorsement decision. Your options are endorse, endorse with conditions, or not endorse.
And I'll just note throughout the conversation, I didn't hear any conditions on the measure that would need to take place in the short term. We noted that during the maintenance cycle, we would be looking at a wide range of potential unintended consequences. So the mobilization issue may come back up then. And the maintenance cycles happen no later than every 5 years. Or if the measure undergoes a big change, then it would come back sooner than that.
The next measure, we'll go ahead and kind of get back rolling with this. This is 2:40 p.m. Eastern. The next measure we had up was 4125. There was one last question from Annie Johnson in the last measure. I know we moved past it, but I know that we still have the developer on the call for that. Just a clarification around the data abstraction, if it includes labor delivery patients. I don't know if Dr. Romano, you want to briefly speak to that, or another member of the team, just to answer that question briefly.
Mia, can you address that? Labor and delivery patients. My understanding is they are included as long as they're inpatients, as long as it's an inpatient encounter.
Okay.
But Mia will correct me if I'm wrong.
Okay. Okay. Mia, are you on? Are you on the call at all? Back from break. Okay, we'll leave the question up there, and maybe Mia can kind of circle back with Amy. But I did want to keep us moving with our next measure on the agenda here today. It's 4120E. This is 30-day risk standardized death rate among surgical inpatients with complications, failure to rescue. This is an outcome measure. It's the percentage of surgical inpatients who experience a complication and then died within 30 days from the date of their first operating room procedure. So failure to rescue is defined as a probability of death given a post-operative complication. We still have our developer on the call, and this is a CMS stewarded measure. It is a new measure. The patient population is 18 to 89, as well as the care setting being hospital inpatient, and it's at the facility level of accountability or analysis. But do we have all the representatives for this measure on the call? Are there any additional that we need to promote from attendees? I believe everyone's here. Is that right, Dr. Romano? Or are we still waiting for Mia?
Dr. Monica Ray is our analytic risk adjustment lead. So if you haven't promoted her, please do so.
Okay. All right. And Monica, can you come off mute? Are you on the call?
I'm here. I'm here.
Great. All right. Thank you. Anyone else, Dr. Romano?
Dr. Utter may help me out as well from the surgical perspective.
And that last name, if you wouldn't mind.
Oh, Dr.
spelling
Utter.
that?
Yes.
I'm present.
Great. Perfect. Okay. All right. So let's continue with this. So if we go to the next slide. Oh, Mia, you have your hand raised. Was there a comment you were going to say?
Apologies, I heard my name and so I came running. I didn't get back on time. So if you could restate the question for me and I'm happy to respond.
Yeah, apologies about this. This was just a follow-up from the last measure. There was just a clarification question around whether the 4120E includes labor and delivery patients, as well as seeing these patients tend to be classified as outpatients. I don't know if you wanted to just briefly answer that.
Yeah, so this measure does not limit the denominator, and it is inclusive of obstetric patients.
And then confirming that's 4120E, correct?
4120E, that is for the falls with major injury, major or moderate injury, correct, yes.
Okay, thank you, thank you. Just answering Amy's question there. Okay, appreciate that. So again, we're now on 4125. So we did have 11 comments received during the public comment period, and you can see those listed out here. One comment required for more specificity. The comment suggested a more narrow and well-scoped list of adverse events that need to close monitoring post-op. 2 comments related to site of death. One comment shared a concern that the measure disagrees or disregards, the site of death, and that this can introduce scenarios outside of the hospital's control. Another comment requested further refinement of the numerator to add exclusions related to site of death. There was also one comment around unintended consequences with this measure, brought attention to the fact that the potential unintended consequence of discouraging patients from shifting their goals away from life-prolonging efforts within 30 days of surgery, and suggested excluding cases where care was appropriately shifted and the natural death occurred. Going to the next slide, some of these other comments on this measure as well. One was around risk adjustments. One comment showed concern for the lack of risk adjustments for this measure. And another comment said that around excessive exclusions, saying that there are excessive exclusions in the denominator, the risk adjustment, and regarding missing information. And there were 2 comments in support of the endorsement prior to its use. So these comments also came from the public commenting opportunity through the pre-rulemaking recommendations work we had earlier this month. So 2 comments recommending that the measure meet endorsement before it actually used in any program, which is ultimately what this body and this committee is doing today. And going to the next slide. If we could. Are we on the next slide? Yeah, thank you. We also had a comment related to just the volume, recommending that testing be conducted to evaluate the measures for volume bias among facilities. And then another comment raising concern with this 30 days and evidence concern here. It did not support the measure due to those concerns of underlying evidence for the expansion to 30 days post-discharge, as well as reliability. And then lastly here, this one comment around unsuitability for use in federal programs, just again raising concern that this measure may not be suitable for federal programs with respect to the concerns with the reliability, risk adjustment, and some of the specifications as well, and the capture of Medicare Advantage patients. And I believe that's the last one. If you can go to the next slide, just might confirm that. Yeah. So let's go back to the description slide. I will now open it up for any member of the public who has any public comments on this measure. You will be an attendee list. You just raise your hand and we'll recognize you to take you off mute, and then you can speak your comment. Any member of the public who'd like to provide a comment for the committee's consideration for 4125. Okay. Last call here, public comments for 4125 before we get into discussion. Okay. All right, so we'll now offer the developer a 3 to 5 minute overview of the measure. Dr. Romano, do I turn that to you or someone else? Okay, Dr. Romano, yes, go right ahead.
Yes, thank you again, Dr. Patrick Romano from UC Davis. We're pleased to present now a claims-based quality measure, 4125, 30-day risk standardized death rate among surgical inpatients with complications, also known as failure to rescue. Again, CMS has supported our work in updating and validating this measure. So this measure concept has a long and colorful history, really. The original concept of this measure of failure to rescue was developed by Jeff Silber at the University of Pennsylvania and his colleagues about 30 years ago. And it has repeatedly been shown to be a strong marker of particularly nursing quality care. So the concept here really is that some patients develop complications after surgery. This measure focuses on the mortality among these patients who experience postoperative complications. So the denominator is limited to patients who had a postoperative complication, and the numerator represents the proportion of those patients who died. Now, Silber and colleagues developed their version of the measure. It was later adapted by Jack Needleman and Peter Buerhaus as part of a large study of nursing quality nationally. And they made some simplifications in the design of the measure. And ARC subsequently, AHRQ, subsequently adopted that measure, the Needleman-Buerhaus version, as PSI 04. Subsequently, CMS incorporated ARC's PSI 4 into its hospital inpatient quality reporting program. Now, in the background, of course, with the previous consensus-based entity, both of these measures had been endorsed by the consensus-based entity, both Silber's original version, if you will, and ARC's version of PSI 4. However, over the years, Silber's version was re-endorsed on 2 occasions. The ARC version of PSI 4 was failed at re-endorsement on the second time. And so the ARC version, PSI 4, which CMS adopted, is not endorsed. The Silber version of the measure was always endorsed until Jeff Silber and his team decided they no longer had the resources to continue going through this laborious process, and they voluntarily withdrew it just a couple of years ago, and they blessed us to carry on the work. So what we're now doing is really going back to the original concept from Silber and colleagues of failure to rescue, and modifying the measure really to make some substantial improvements. There have been a number of criticisms of PSI 4 through the years. One is that some of the complications actually developed before the index operation, and the index operation is really part of the effort to rescue the patient from a prior complication. So that's one problem with the current PSI 4 measure. The cohort is very heterogeneous and includes some high-risk surgery like trauma surgery, burn surgery, organ transplants. So some hospitals have expressed concerns about this. Also, we know that hospitals vary in their mean length of stay and their patterns in terms of when they discharge patients and where they discharge patients. So as a result of all these factors, it's been shown that PSI 4 slightly disadvantages teaching hospitals, even after risk adjustment. I'll say that it's a modest effect, but it's on the order of 1% or 2%. It's a slight disadvantage against teaching hospitals. So by going back to the original Silber concept of failure to rescue, we've implemented now 3 major differences. One is that we capture all deaths among denominator eligible patients occurring within 30 days of the first qualifying operating room procedure, regardless of where the death occurs. We'll talk about that more. We limit the denominator to patients in general surgical, vascular, and orthopedic MSDRGs or surgery categories as a way of making the input population a little bit more homogeneous, a little bit more consistent, really elective or semi-elective surgery. And finally, we exclude patients where the procedure followed the complication rather than preceding it. And on the other hand, we also broaden our definition of denominator triggering complications to ensure that we're capturing all the complications that may predispose to death, including some complications that are not captured in the current PSI 4. So as a result of these changes, I think we're bringing a measure now back into the measure endorsement process that is very similar, updated version of Silber's measure, and it has greatly enhanced reliability at the accountable entity level, as well as enhanced construct validity based on analyses of 2,055 hospitals. Also, I'll point out that this is an all-payer this is an all Medicare claims-based measure. So it also has the advantage now of including Medicare Advantage patients as well as Medicare fee-for-service. So we look forward to further discussion of the measure. And again, we're building on a 30-year history of work on this concept. And we're excited to bring this measure back into the endorsement process.
Great. Thank you, Dr. Romano, and also for touching on some of those comments that we received from members of the public. Also, I'll turn it over to the recommendations group, see if there's any clarifying questions from the group. So if there are, please go ahead and raise your hand. Any clarifying questions about the measure you'd like to have from the developer? Go ahead and raise your hand, or you can take yourself off mute from your recommendations group member. Okay. All right. Again, clarifying questions from anyone? Okay. Okay, so let's go into our first domain, which is important. So we'll get to that slide. Thank you. So for this one, we had 18 participants submitting reviews. As you can see, there was consensus among those 18 of being met, 94%, pretty high. The staff preliminary assessment was also met, also recognizing a business case for the measure. There's also evidence to support the claims for that business case. And you can see that also came through from those 18 members as well. There's also a recognition of the gap in care that exists currently, also positive support for the measure. There was a comment around some limitations that some of the evidence within the supporting information was about 30 years old. So that was sort of one of the limitations there. But I'll open it up to see if recommendations group members, any feeling here on the strengths and or limitations, especially limitations, did you find any concern with the 30 years? Anyone have any concerns with that? Did you feel the same or not? I'll see if oh, thank you. So I'll see Mary Beth or Whitney. Anything from your perspective on this? Any issues with the literature here with this one comment?
Sorry, having trouble with the mute. No, I think Dr. Romano covered some of this. You know, we had this before quite some time ago, and glad to see it's coming around again, because I think it's an important aspect to care, and it does reflect nursing care quite a bit. So.
Great, thanks, Mary Beth. And how about you, Whitney, especially from maybe the patient perspective with this type of measure? Any concerns, anything you need to talk about?
By and large, the overall rankings on importance were very strong. Everyone was really supportive of seeing this come back to life and start documenting some components. Where more of the comments are coming in are in later categories around the specifics and needs to recognize other pieces of patient experiences. So I'm happy to speak to those comments when we get there. I mean, obviously, like, none of our kids can submit something with evidence that's 30 plus years old. So it's always a concern and a flag to raise. But I do think some of the other pieces of the assessment and evaluation of this measure really stand for itself.
Great. All right. Thank you, Whitney. Any
just
other,
to clarify, Matt, just to clarify, is this pertaining only to Medicare patients? That's all? Is that correct?
So
am I correct?
I believe that Dr. Romano confirmed that, but Dr. Romano,
okay.
Go right ahead if you'd like to.
Yes, so the measure that we're bringing to you today is designed for Medicare patients, including both Medicare fee-for-service and Medicare Advantage. Obviously, others may choose to apply the measure to a broader population, but because it's a claims-based measure that's in CMS's portfolio, it is currently specified for Medicare only.
Okay, thank you.
I should also, I have to point out that the fact that the literature goes back 30 years doesn't change the fact that it's been consistent over the 30 years since then. So we have cited multiple studies from 2013, 2015, so forth. So this has been a consistent finding that has been replicated many times during the subsequent years.
Thank you, Dr. Romano. So adding that even there's a limitations noted here, but the literature, even coming up to more current literature, is very consistent over the past 30 years, which is also a very strong finding itself too. Are any other comments on importance here? Let's see, just double checking.
Oh, I guess I would just add quickly that I feel like that last bit is actually quite persuasive, is that the data are old, but if they're replicated, and it sounds like it's still a problem. And I found that bit of information very persuasive.
Oh, that's great. Thanks, Jason. Thanks, Jason, for that. Dr. Romano, maybe there is a question. It says in our Q&A here, is how this measure fits into Medicare's measure portfolio. And, thinking about importance, part of that is thinking about, why is this measure itself important versus other healthcare measures or things that could be in existence. So there was a question about how this really fits into the portfolio. There's several condition and procedure-specific mortality complication measures. So I don't know if you wanted to speak to that. And then secondly, if this is a Medicare-focused measure, why are they 18 plus in there? I would state that it's because patients less than 65 can be eligible for Medicare if they have certain disabilities, but I'll definitely let you and your team maybe speak to those two questions.
Yes, that's correct. So to Dr. Suter's question, yes, so this measure has been designed to be compatible, if you will, with CMS's existing portfolio of, where'd the question go? I just lost the question. Oh.
It went into the answered bucket, Patrick.
I'm sorry, I hadn't answered it yet.
Yeah.
Okay.
Sorry. It's at the very bottom of the answered bucket, Dr. Romano.
Okay, right. So this measure is designed to be compatible with CMS's existing portfolio of 30-day risk standardized mortality measures. As the committee may be aware, CMS had proposed a couple of years ago to retire PSI-4 from its hospital inpatient quality reporting program entirely. And there were a lot of complaints that came back, a lot of concern from the stakeholder community, that people really wanted a measure that was focused on surgical patients, particularly elective and semi-elective urgent surgical patients, that really represented this concept of failure to rescue. And so we were commissioned to undertake that process of basically revising PSI-4 as a broader failure to rescue measure in a way that would make it consistent with CMS's existing portfolio and also address stakeholder concerns. I will say also that there is an existing measure of 30-day coronary artery bypass graft surgery mortality, and those patients are specifically excluded from this measure to avoid sort of double counting certain deaths in that way. Okay, back to the other question about Medicare, and I think Matt has already addressed that question, which is that we do have a substantial population of patients with end-stage kidney disease, as well as patients with permanent disabilities who are Medicare eligible before age 65. And so we do believe that those patients are at risk for failure to rescue. And so they are included in the measure with appropriate risk adjustment to account for their conditions.
Thank you, Dr. Romano. Okay, any other comments from the committee, recommendations group members as well here on importance before we go to feasibility? Okay, great. So let's go to feasibility on this one. As Dr. Romano had mentioned, this is a claims-based measure, so that was also one of the strengths because it's an electronic source, so it helps with some of the burden with the measure, which the staff assessment also mentions as well. So the staff assessment for this was met And you can see of those 18, it was 100% on MET, not finding any really limitations. But I just wanted to pause here to see if that, just confirm that. Again, with feasibility, we're looking to see how well the measure can actually be implemented and used, right? And any undue burden to actually capture the data or workflows for the providers. So any comments on feasibility from the committee? 100% of those voting said met. Okay. Whitney or Mary Beth, anything from you both? No?
Not on this one,
No.
but I'll hit you up next time.
Okay. All right. Sounds good. Well, then let's go. Let's keep moving forward. We're going to sign of acceptability here next. So we're looking at, again, the reliability and validity. And like I mentioned previously, when we looked at these, we expanded those two concepts. And then we chose the lower rating of the two. So that's why we have not met but addressable here. The staff assessment on this was also not met but addressable, really due to the reliability counts here, where we approximated about 50 to 55% of entities have reliability less than the thresholds of 0.6, which maybe our developer can sort of speak to that. But that was also a limitation that was pointed out here as well. Another mention of higher reliability may be difficult to achieve given limitations of the claims data, and raising the minimum case threshold to extending the reporting time frame may not achieve the desired outcome. So mentioning even just raising the case minimum may not be what's needed to help achieve the outcome. But before going into and see if the developer wants to respond to some of these limitations, especially about the reliability, any additional comments from the committee, any additional questions related to scientific acceptability? And that can also include validity as well.
Matt, would it actually be okay if Dr. Romano responded to the comments that were submitted, and then I can highlight?
Certainly.
That would be great. Thank you.
Yeah, certainly. That's perfectly fine. Yeah, so Dr. Romano, if you wanted to speak to any of the reliability estimates or limitations that were mentioned.
Yes, I can. So, so first of all, just to set the context a little bit, the current PSI-4 measure, which CMS is using in its HQR program, has an accountable entity level reliability around 0.256 on average. So everything we're looking at here is dramatically better than the measure that's currently being used. So I just want to kind of set that context. And the reason for that, by the way, is two things. One is the addition of Medicare Advantage patients along with Medicare fee-for-service patients. And the second reason is broadening the set of complications that go into the denominator. So the current measure is limited to 5 categories of complications, and the measure that we're discussing today has about 3 times as many types of complications that go into the denominator. Now, with respect to the reliability estimates that we submitted, so we've done a fair amount of work subsequent to the PQM submission to really explore this issue in more detail and understand what could we do to address it. And so we discovered a couple of things. One is that in our test data set, the number of inpatient surgical encounters was artificially depressed by the pandemic in 2020, the second half of 2020 and the first half of 2021. So as we look towards more recent data that we've now incorporated through 2022 in our testing, we see that hospital volumes have increased. And this is of course good news because as the hospital volumes increase, the reliability of the measure at the hospital level also improves. We also found that a fairly modest adjustment to the minimum volume threshold could have a significant impact here. So the current minimum volume threshold that is set by CMS is 25. If we were to increase that minimum volume threshold modestly, let's say to 65 or so, we in fact would at that point find that the median value for the reliability would go up to 0.724. And in addition to that, we found that only 30% of facilities would have ICC, signal to noise ICC ratios under 0.6, only 30% instead of 50 to 55%. So basically, with some fairly modest changes, given increasing volume of surgery and possibly a change to the minimum volume threshold for reporting, we can bring this measure up into, I think, what everybody would accept as an appropriate reliability threshold, with only 30% of facilities being below 0.6. I will point out, of course, that this is a problem that affects all risk-adjusted mortality, risk-adjusted readmission measures. So I think all measure developers and CMS have been struggling with this issue of improving reliability. And so we would aim to, of course, work in concert with CMS and with other measure developers to take a systematic approach.
Thanks, Dr. Romano. And I'm sorry, Whitney, I'll make sure to turn to you. I think it's an important point. It's because what you had mentioned is, as you increase the sample, right, the reliability goes up. So maybe it's not the measure necessarily being unreliable. It's really just at a certain population size or case volume, it's harder to detect that signal reliably. So that's why we see, those smaller facilities having lower reliability estimates. So I think it's a good point to point out there. But Whitney, I don't know if you had a follow-up there, and then I also wanted to draw attention to Tariq's question in the Q&A.
I did have a follow-up, and then I'm happy to be the voice of Tariq on this. I know that there's been a little glitch in his Q&As, but Dr. Romano, I was wondering, there are a handful of submitted comments and my own, and I know different models are in place across like the vaccine error reporting system and some of these other things. But first, do these then become adverse events and reported as such at the hospital? I realize that's outside the quality measure moving forward, but I was curious because I do think that that's an important data set for patients to have access to as we advocate for things out in the world. And then secondly, there are things in a patient's life. Some of the comments reflected social determinants. Some of them reflected community access to programs and things like that at discharge, et cetera, et cetera. Are there things like that that need to be better accounted for in this measure? Or are they things that are, forgive the phrase, acceptable risk, much like a clinical trial documents any death of any clinical trial participant, regardless of cause?
Yeah, I'm not sure I fully understood the first question, but I'll address the second question, and then we'll come back. So this is a tricky question of, do we design our measures? Do we design clinical research, for that matter, as you point out, Whitney, to capture all-cause mortality? Or do we make an effort to actually attribute each death to the preceding operation or not? And we wrestled with this question extensively. And I think that we kind of joined the historical consensus that's emerged over the last 20 years, that it really just introduces bias to try to figure out for each death which factors contributed to that death. I mean, just for example, we see, frankly, patients who commit suicide within 30 days after an operation. And you might say, well, that's clearly unrelated. But on the other hand, we also see that many of these patients, in some cases, these patients complained of pain, complained of consequences of the surgery. And so their suicide may have been related in an indirect way. So this is why, both in clinical research and in measurement, We tend to favor this all-cause approach to identifying deaths, recognizing that, yeah, we're probably picking up a few deaths that are truly unrelated to the prior operation. But it is a very small proportion, on the order of 5%, 10%. One of the things that we do to look at that mathematically is to look at the hazard function for when patients die after a major operation. And we can basically plot out when their hazard function comes down to their baseline risk, right? So after about 30 days, people's risk drops to their baseline level of risk. And it's clear that if we cut off before about 3 weeks, we're going to be missing a substantial portion of the deaths that are actually attributable to the prior surgery. So the sweet spot seems to be somewhere in there between about 3 weeks and about a month or so, 5-6 weeks. And so 30 days has become the historical convention, of course. Dr. Suter's group and others have long developed 30-day measures for heart attack, stroke, heart failure, coronary bypass surgery, so forth. And for all of these measures, we understand that some of the deaths are probably not linkable to the preceding condition, but we're very concerned about the bias that results from differences in when and how patients are discharged from different hospitals. Using the 30-day metric across the board for every patient allows us to say that we're treating every hospital equally.
Thank you, Dr.
Great, thank
Romano.
you. Matt, do you want to
Oh, go ahead.
Yeah, I was going to say, do you want to take Tarek's question?
Right, and I think it was somewhat touched on during this too, Whitney. Thank you. It's just Dr. Romano asked me to expand about the potential limitations related to the claims data, but also, are there concerns or with comparing hospitals that have this mixture of Medicare Advantage versus Medicare fee-for-service as well?
Well, I think that obviously the bigger concern here is that patients are increasingly shifting, enrollees are shifting into Medicare Advantage plans. And so we're now about 50-50 split between Medicare Advantage and Medicare fee-for-service. So our concern is sort of the opposite, that as we continue to focus measurement only on Medicare fee-for-service patients, we're missing too big a piece of what's going on. And to really understand the full picture, we need to look at both the Medicare fee-for-service and Medicare Advantage enrollees. There has been historically some concern about the completeness of claims for Medicare Advantage, but I think that issue has generally been resolved for the inpatient claims in particular. And this is an inpatient measure that relies on inpatient claims that are linked to subsequent verified deaths from the CMS and Social Security death registry.
Great, thank you, Dr. Romano. And then there was just a comment mentioning that suicide is not unrelated, considerable correlation between chronic pain and suicide. So suicide should be tracked as a follow-up. I don't know if you have any comments on that specifically for this measure, but maybe that's definitely something that the institutions also can start to target. But any comments on that comment, Dr. Romano?
Nothing further. I apologize for not using the optimal terminology. Of course, Whitney's correct, and Verma. So this is definitely, just really an example of how we can't really anticipate all the things that will happen during this key period of vulnerability after a major operation. I'll just ask if Dr. Utter, if you'd like to add anything from the surgical perspective on this.
Sorry, Patrick, for a specific part of the discussion?
Well, about the issue of post-discharge deaths and to what extent it's fair, if you will, to blame the hospital for those post-discharge deaths within 30 days of the operation.
Yes, well, certainly, there's a history here of, concern about hospitals discharging patients, rather abruptly to other settings, potentially to avoid responsibility, and those other settings could include skilled nursing facility, other acute care hospitals and so on. So I think this measure, now is designed to much better address that issue. In extreme situations, I suppose, hospitals could, be perversely led to try to keep patients alive until, 31 days or later after an operation, but that's pretty unusual, and of course has drawn attention in the rare circumstances where it's arisen. Were there other aspects you wanted me to address?
No, that's fine. And I just wanted to also ask Dr. Ray if you wanted to add anything from the reliability perspective.
No, I think we got to fill in some of the unexpected increases in data since our submission. So we do not have the case of half of the facilities having reliability thresholds. So
Yeah, so we'll be happy to update the record with some of those additional simulation analyses that show that that reliability issue is definitely addressable. And
Great.
Dr. Walsby's point, thank you for that point, that to create distortion in the quality metric, it would have to be differentially associated among hospitals in frequency.
Great.
Sure thing. And if I can jump into, Rep Rosie's comment for her, it was identically aligned to the earlier comment I made about adverse event reporting. I think hospital-acquired infection rates and some of these other things are very real complications. And it sounds like Rosie was one of the individuals in the world that was lucky enough to receive an intervention that saved her life. So Rosie, we're grateful that you're here with us. I think that's a perfect example. Does it also get reported as an HAI? Does it also go through this quality measure? Or does this quality measure create an unintended consequence that someone might step away from other reporting vessels for the impact of what might have happened?
Yeah. Okay. Thank you, Whitney. Thank you, Rosie, as well. Any other comments or questions here for reliability and validity for the developer? So just to circle back, Dr. Romano, you had mentioned that you could update the record or maybe some of the testing data with some simulation analyses, specifically with reliability. As you had mentioned, if you increased it to 65 for the minimum case volume, you actually saw acceptable reliability with only about 30% of facilities not meeting that 0.7 or a 0.6 or higher, excuse me. So these simulation analyses could be something that could help to show that there's some reliability or alleviate some of those concerns. Is that what I heard from you? Yes. Okay.
Yes.
So maybe that could be a condition for the maintenance endorsement. So that would be something when it comes back through, maybe some more analyses there to expand on the reliability concern. Mary Beth, Whitney, would you agree, or is there anything else that we missed on that one?
No, I think you covered it pretty thoroughly between Dr. Romano and others. So I think we're good.
Great, thank you.
Okay, great. Thank you, Dr. Romano. Okay, so let's keep going. Not seeing any more comments or questions there. So just next one is equity. Also had good consensus here for those that were evaluated this measure with 100%, noting strengths around potential disparities that are associated with race and ethnicity, age and sex. They were evaluated and reported, really not noting any additional limitations. But I will open it up to see if anyone from the committee has any additional comments here. Again, equity here is trying to see if the actual measure can identify those disparities by maybe stratification, and are those disparities significant? The intent here is ultimately that maybe the measure can be used as a tool to target certain populations and ensure that disparities can be closed. Any comments here from the committee on equity, this optional domain? Okay, great. So that's great. So next one is use and usability here. This also was met out of the 18 respondents. So this being a new measure, we're wanting to see if there's a plan for use. All right, so we're looking to see if the developer has reported that, and the developer does report that it is a plan for use in public reporting. Also, a strength that was identified here in the staff preliminary assessment, it also drew attention to this as this domain being met. Was also literature review cites a range of facility level interventions hospitals can use to improve performance. So that's really where we're getting to this usability concept, right? What are those things that providers can do, or these facilities can do, can actually prove the performance here? And the literature cited shows that. So it'll be interesting to see in about 5 years if this measure is endorsed, you know, if that needle is moving at all, if it will be implemented pretty soon or not. Some concerns, though, noted that were expressed about public reporting before the reliability limitations. But I think we discussed this here, is that the measure itself it's not in and itself not reliable. It's the fact that the patient population, if you expand it or you shrink it, can mean that the facilities themselves reporting on that measure may not have a reliable signal. So there are some concerns with reliability, but one of the conditions we mentioned was that the developer will do some additional simulations for the next time this measure comes back through to alleviate some of the reliability concerns there. And the measure might not be useful for facilities without a sizable Medicaid population or Medicare population, excuse me, kind of coming back to, again, some of the reliability concerns there. Any comments, questions from the group? I mean, anything that stuck out here with you, anything you're really feeling strongly about or even very supportive about as well? Any comments from the recommendations group or others? Okay. Whitney or Mary Beth, anything that we missed, anything you noticed?
I haven't seen anything. I think it was a pretty thorough review. So I'm good with it, with what we did.
Right.
Similarly, Matt. Thank you.
Thanks, Whitney. Thanks, Mary Beth. Okay, before we go to a vote, Dr. Romano or team, any other final comments on the measure or anything the committee can consider before voting?
Well, I think I appreciate your consideration and appreciate the opportunity to and the stimulation to perform additional analyses to try to address this reliability issue. I will also say that as many of you know, nurse staffing, nursing skill mix, nurse training has become an increasing issue across the country. Hospitals are struggling with nursing burnout. Several states have now implemented or are in the process of implementing various kinds of regulations related to nurse staffing. And a consistent finding that we support, our work has supported, is that the best single thing that hospitals can do to improve performance on this measure is to improve their nursing skill mix and nurse staffing, because that leads to earlier identification of complications, more effective interventions to treat those complications, and more effective teamwork with physicians, respiratory therapists, physical therapists, other team members to treat those complications before they progress and ultimately, unfortunately, lead to death. So we look forward to seeing this measure implemented and further dialogue.
Thank you so much, Dr. Romano, and as well the development team on this measure. I'm going to open up the vote here. Again, we are still not going to have full voting quorum, but please go ahead and submit your votes So let me just ask Elena if she could open up that vote and we can read off our measure questions. Go right ahead.
Hey, Matt, there's no conditions associated with the vote, right?
Sorry, Mary Beth, thank you. Yes, there is a condition. So when you're submitting your vote, the condition here for this measure is that there will be updated, the developer will update the reliability testing by doing additional simulations to alleviate some of the reliability concerns that were identified. So that is the condition placed on this measure. So if you go to endorse the measure, it means you don't feel like there's a condition that needs to be placed. You are fine with how the measure is. And the condition here is that it's related to the reliability testing, which the developer would conduct more simulations around that when the measure comes back through. And of course, not endorse means you don't think, based on something else that was mentioned that was a major concern, you don't think it should move forward. All right, Elena, yep, go ahead. We're going to go to our last measure of the day, which is 0694. That's hospital risk standardized complication rate following implantation of implantable cardioverter defibrillator, ICD. The developer and steward for this measure is the American College of Cardiology, and I do want to check in. Do we have a representative from ACC on the call? Looks like we have a hand raised in the attendee list. Yes, can we promote both Katie Goodwin and Heidi Bosley, please? And Heidi and Katie, are you able to come off mute now?
Hi, Matt. Thank you. Can you hear me?
Yes, can hear you.
Thank you. I had also, if we're to raise our hands to get speaking capabilities, if Jepta, Curtis, and Carl from Yale could also raise your hands.
Yes. Yes, if there's anyone else to speak on behalf of the ACC measure, please raise your hand in the attendee list, and we will promote you.
And Matt, this is Heidi. I think you can hear me. I'm also speaking.
Yes, we can.
Okay, great.
Thanks, Heidi. Thank you. Okay, and then we have Christina Blankenship. All right. Again, if you're with the ACC and will be speaking on behalf of the measure, please raise your hand in the attendee list, and we will go ahead and promote you so you can take yourself off mute and chat with everyone. But since we have Katie on and Heidi, are you okay if we proceed? I think we promoted everyone that you had mentioned.
Sure, I think that's fine.
All right, great. Sounds good. Okay, so like I mentioned, 0694, this is a maintenance measure. So this measure, the older the number, or I guess the smaller the number, right? So we're 0694, the older the measure. So this measure has been around for a while. It is a maintenance measure. It is coming back through as for maintenance endorsement. It looks at the measure provides hospital-specific risk standardized rates of the procedural complications following implantation of an implantable cardioverter defibrillator, or ICD, in patients at least 65 years of age. The measure uses clinical data available through the National Cardiovascular Data Registry, or NCDR, Electrophysiology Device Implant Registry, or EPDI, for risk adjustment linked with administrative claims data using indirect patient identifiers to identify procedural complications. So it's an outcome measure. We mentioned the age population being greater than 65. It is looked at in different care settings, both the clinician office or clinic, as well as hospital inpatient settings, and it's at the facility level of analysis. To go to the next slide, we'll point out that no public comments were received for this measure during the public comment period, but we'll see if any member of the public is currently on the call that would like to provide their comment. You can raise your hand and we will recognize you to speak your comment. So opening up before we get into discussions for public comment. Again, the public comment on 0694. Okay. All right, not hearing any. Let's go back to the description slide. I'll also note with this measure, Jason Lasby, you are recused, but that does not mean that you cannot participate in the discussion. You just won't vote when we go to vote. So now we'll give it over to the developer to do a 3 to 5 minute overview of the measure. So Katie, Heidi, turn it to you.
Sure, and that's going to be me. As was probably became clear, we have a few additional individuals on the phone, so I'll be the primary person answering questions, but may very well refer specific items to some of the other folks on the call. I'm a consultant for ACC and have worked with them for many years. We wanted to provide some background because this measure is different from what you would typically see from ACC. Traditionally, measures that come through, and there are over 11 measures that are currently endorsed, developed, and maintained by ACC. And we present new testing, new performance data, all of the updates for those measures. The measure that you have here before you today is unusual in that way because of challenges with access to the administrative claims data, and I'll talk about that in just a minute. ACC maintains procedural data registries really with the goal of advancing quality in cardiovascular medicine, and we recognize the importance of achieving consensus-based endorsement on measures. This measure was first endorsed in 2011, went through re-endorsement in 2016, and then honestly has been postponed for reviews with the previous contractor because of our ongoing desire to get access to the administrative claims data. So this measure was developed with CMS claims data linked to NCDR registry data through ACC's status as an approved CMS Research Data Analytics Center, or through RESDAC. While CMS grants access to claims data for purposes of measure development, we cannot use that same vehicle to use that data for measure implementation. We also, at ACC, explored getting access to the data through the qualified entity QE mechanism because the registry does not meet the CMS definition for a qualified clinical data registry, which is another vehicle through the MIPS program or the quality payment program that can be used. The QCDR program is a narrowly defined process that does not align operationally with how NCDR registries are designed. And so because of those pieces, ACC has exhausted the vehicles by which data for implementation can be achieved. ACC has spent significant time actively working with a coalition of other medical specialty societies to introduce federal legislation, particularly under the Expanded Access to Claims Data to Facilitate Research and Quality Improvement Act, which would empower HHS and CMS to remove regulatory barriers to permit this measure and other measures to use the claims data. And unfortunately, that legislative language did not go through and has not been enacted yet. ACC is partnering with STS and the orthopedic surgeons, AAOS, to reintroduce legislation with the current Congress in an attempt to do this. But that just, again, is background on why you see previous data from the last endorsement review in 2016, why we were unable to update the gap data. We did, outside of this, and we can provide this written if it's helpful, but we did perform a literature search to see if we could at least supplement the lack of actual data on this measure. We found a meta-analysis that demonstrated an overall complication rate of just over 9%, and the majority of the complications were due to access issues or lead displacement. Infection rates were about 1.5%. Another retrospective study of Medicare beneficiaries who had an ICD placed for the first time found that over 5% experience a complication during their inpatient stay, and roughly 7% have one within 90 days of implantation. In an adjusted analysis, that same study found that the complications within 90 days of implantation were associated with an increased risk of all-cause mortality at year 1 and 3 years. So again, we're happy to answer any questions you may have. We can go back and try to explain the testing previously. I know there were some concerns around reliability, but this is just an unusual instance where we do not have data for implementation, and acknowledge that at this point, it just needs to go through endorsement review. Thank you.
Great. Thank you so much, Heidi. Appreciate that. And if you do have those numbers available, maybe just you could drop them into the chat for the panelists' consideration. I know you were mentioning verbally as well. I heard greater than 9% in complication rates. I think some of those were 1.5% being infections. Greater than 5% experiencing some sort of a complication, and some of the literature that you were looking at could be helpful to consider. And I'd like to have the committee kind of keep this in mind as you saw through some of your review, as well as other committee members drawing attention to some of the data availability issues. And so with gap and performance gap, which was the first domain that we'll talk about, obviously looking to see if there really is truly a gap in care that exists, and looking at either seeing if the rate of the measure itself is less than what is nationally acceptable, less than optimal, or there's variation that you can see around that rate that is pointing to that obviously the gap that exists. We're trying to narrow that gap. So some of this information can come straight from the analyses developers perform, also something that literature reviews can also point to indicate that there still is a gap in care here, supporting the business case of the measure. So I'm going to open it up to the committee, to especially maybe those who have experience with these type of procedures, as well as thinking about these complications that result from these type of procedures, to weigh in as well. But any clarifying questions from the group, anything that you need some assistance understanding about the measure? Anything out there? Okay. Not hearing any clarifying questions. Mary Beth or Whitney, anything that you wanted to draw attention to?
Heidi, I think you answered it in your, as I perused through the information. This measure is not in use right now, is that correct?
Correct, because we can't link it to the administrative claims data. So because of that, it is not. That's correct.
Okay. Did you have test hospitals or things to do? I guess you didn't at this point, right?
No, at this point, no. And it's been,
Okay.
Policy to focus on the measures that they can implement. But this is an important outcome, right?
Yeah.
So it's a bit of a quandary, honestly.
Yeah, you found it.
100%, yes.
I was curious,
Mary
Matt,
Beth.
would you be able to offer some insider expertise on the, I'm feeling a little tortured. It simultaneously is extremely important, and I want it to go forward to allow for the accounting that can be accounted for. I'm also really struggling with it. I'm just boggled that the information can't be provided and that we're all just kind of stuck having to consider something that we could be refining at this interval to better address the data that we can't see. If that makes sense. I appreciate the candor from ACC and the data that you were able to pull. I'm curious, Matt, if there's any sort of decision internally or something that we can point to in this instance.
Yeah. And this is strictly related to about the access of data and the not ability of that, right? So there, like I mentioned with performance gap, right? There's something that we want to see, especially for a maintenance measure, if the gap is closing or there's still a gap that exists. That gap, like I mentioned, could come from the developer's own analysis of the measure or through the implementation of the measure. There's also supportive literature, which the developer has cited, definitely under consideration for the committee as well, that shows that there may be a gap in care. And that really is going to be dependent on some of the expertise around this table, around this committee, especially for those that maybe have seen these types of surgeries or know about these types of complications. It's based on your review of the literature or your experience. Is there a gap in care here? Is there something that this measure needs to be in existence in order to close it? with the improvement over time, the use of the measure over time, we do want to see that this measure is being used, which, as I mentioned, it's not. So that makes it very challenging to understand if there's any movement of the gap or any closure of the gap over time, as well as what providers are giving feedback on about the measure to understand how to actually improve on the measure. And if that's changed the measure in any way, that may be a little bit challenging. That comes into the use and usability piece. And if there's really no data there, the committee has to fall back on the rubric itself within the televaluation proceedings, which really does want to see that there's a change in care over time. If there's no change in care over time, what's the rationale the developer provided? Also, testing is another area where data is obviously important. Now, the developer had done some testing, and we can definitely touch on this previously, had done some testing to look at the data elements themselves, and they have a process, the NCDR has a process to further validate the data elements that are used within it. What we also want to be able to see, though, and this also comes from the committee's experiences, do care processes change over time? Because the data that the developer had provided are significantly older, 10 plus years older for some of this reliability and validity testing. Do the processes of care have changed significantly over time to where now those data elements may be a little bit questionable? The expectation for maintenance measures, especially as we go in through the Patel process and moving forward, is we'd like to start seeing more what we call accountable entity level testing. So that's looking at the measure score, not necessarily the data elements themselves. Just trying to see if the score itself is reliable or valid. We talked a little bit about measure score reliability with the previous measure and those thresholds. So we want to be able to start seeing this score level type of testing, even though it's not specifically called out, or it's not specifically called out for this measure with updated data. So it then comes back to the committee to see if there's confidence that you have based on the prior testing that are 10 plus years old, if there's any changes that have happened with workflow, is this measure still have the data elements to be reliable and valid? So Whitney, does that help answer some of your questions, or do you want me to clarify anything that I mentioned?
I'm good, thank you.
Marjorie, you had your hand up as well. Did you have a clarifying question? I apologize if I didn't recognize you.
No, Whitney had expressed some of the same concerns I had, so thank you.
Sure, of course. All right. Any other clarifying questions? Any other things you want to clarify with the developer before we get started? Okay, let's go to importance here. So you can see there's no consensus on this. We almost reached consensus with the not met. Some of the strengths, well, at least with the staff preliminary assessment, this was also a not met. This was the not met from the preliminary assessment was due to the lack of the performance data, understand if there's a gap in care. Again, that helps establish this business case for the measure. The developer did report out some results, some of which were dropped into the chat, the results that were verbalized during opening remarks. But that's where the limitations were for this measure. Does anyone have any questions related to some of those results, or even some of the evidence that maybe that you know of related to this gap? Anyone on the call? I thought I heard somebody might come off.
Yeah, you have, the results here. What year were they done in? I mean, how far back are we looking at here?
Sure. So let me just pull up. I have the publication dates at a minimum. The meta-analysis was published in 2015. The second one with the Medicare beneficiaries, the retrospective study, was published in 2018. I'd have to go back into the actual publications to see the year of data.
Yep. Okay, that works. Thanks.
Sure.
Anyone on the call, especially if you have experience with this area of care, do some of these rates that have been quoted by the developer align with your understanding and experience of the literature? And while maybe folks are thinking about that, there is a question in our Q&A. Will it be better to include the risk factors into the EPDI system instead of waiting to the legislative measures to access the data? So don't know if Heidi, you want to be able to speak to that. So, including those risk factors in the system as opposed to waiting for the data.
Sure. So I'm going to ask Katie or Christina to answer to that specifically, since they work with the registries directly.
Thanks, Heidi. Christina, are you able to answer that?
Sorry, I had to get off of mute. Can I to reframe it to make sure I understood correctly? It was whether we should proceed with this measure and not in a way that doesn't require mapping to the CMS data as best we can, or did
I think the question was, right. It was, will it be better to include the risk factors into EPDI, into the EPDI system? So maybe some of these data sources that could be potential risk factors, or even the data elements themselves, try to include that into the EPDI system rather than waiting for legislative changes to access the measured data.
Oh, sure. We do have an inpatient model, which is quite similar. It doesn't have all the same components, but it is similar. And we do report that because we can't capture the data prior to the patient being discharged. It's this 30-day, 60-day, follow-up that creates a little bit of a burden to a hospital, and we were relying at one point on CMS to provide us that follow-up data instead. So we're again trying to balance the hospital's availability to provide us this data with the reporting of it. But so I guess it is difficult for us to obtain complete 30-day follow-up data. We would need some sort of more incentive, like a measure perhaps, but we do have data at discharge that perhaps we could propose using that measure as well. So
Christina's Jeff Curtis, if I could just chime in there. I think two parts to the answer is that yes, we do have the in-hospital model, and that's part of what the benchmark reports to our hospitals include. But specific for ICDs, many of the complications and the very important ones, including infection, really aren't going to become available or apparent in that first 24 hours. And that's what most of our procedures are conducted as, either outpatient hospital procedures or outpatient procedures. So, I think to get to the true heart of this measure and where the quality gap we still suspect would require that longer term follow-up, which is just out of the scope of what the NCDR can have or can provide. So I think, from our standpoint, this link is critical to the measure.
And Christina, not to put you on the spot, but do you have any of the complication rates and how it has changed, at least for the inpatient, available to share? That might be helpful.
I don't have the trends over the past 10 years, but we still are seeing a reportable complication rate. It's lower than our 30-day, but it's still hovering around 5%.
Okay. I'll again turn to the committee. If anyone on the committee has any experience with this, is this something that these complication rates, do you find that there still is a gap? Are the rates being reported something that aligns with your understanding of the evidence or not? And maybe I'll just ask Heidi, we may have already mentioned this, but the efforts to try to get access to data, is this something you think would be something near term or long term? Do you have a sense of when you might receive data access at all, or how's that looking?
Well, I mean, it's going to take an act of Congress, for better or for worse, right? As it stands right now, because we can't leverage the other options that are available. The hope is that in this next congressional cycle, that can be brought forward. And then obviously we'll see how quickly CMS is able to accommodate it. I know that ACC is set up to be able to accept this data. Christina and Katie, feel free to add anything else. So as soon as it's available, I think there are plans to move forward on this, but we're very dependent on having that approval for implementation data.
Thank you, Heidi. I want to keep us moving, so I'll just, again, any comments from the group on some of the complication rates that were provided? Anything that you disagree with here? Otherwise, we'll move forward. So I think, Kurt, would you mind dropping your message into the Q&A? The way we can sort of just monitor it that way. So any other, especially from the recommendations group as well, any other comments? I'll move forward as Kurt is dropping his Q&A in, but any other comments on importance first? Okay, let's touch on feasibility and we'll circle back to what Kurt is going to put in the Q&A. This one was a consensus of MET. All the data elements are in defined fields, whether it be claims data or registry data. We also had this as a MET under the staff assessment. Really the limitation here, not all hospitals are reporting to the data registry, and the extent of missingness is not really provided. So maybe I'll turn to the developer to speak to that limitation, and then we can kind of circle back with Kurt and then open it up to see if anyone else has anything else on feasibility. But Heidi or Katie, anything about the limitation there that's noted?
Sure. Katie or Christina, do you have any information on the number of hospitals that traditionally report through the EPDI registry? That might be helpful for groups to know.
I couldn't. At one point, we did have a mandate for participation in this registry. The mandate has gone away, so our numbers have decreased, but we still have a significant number of a high volume registry.
Do you have a sense of what that number might be?
I believe last count it was, yeah, 600, 800.
600, 800, okay. Okay, great, thank you. As we're waiting for maybe Kurt to type his message in, so anyone else have any concerns or comments related to feasibility of the measure? Okay. All right, we'll keep going. We'll go to sign of acceptability. This is where we also have some comments here for the developer's consideration, but a lot of what we already touched on. For the staff assessment, this was not met. There was a split half reliability estimate that was lower than the acceptable threshold, which under the Patel rubric, it's a 0.6 for split half reliability. This is where you're taking the measure score, or at least you're taking the sample that you're going to use to calculate the measure score, and you split them in half, and then you calculate the measure score in both and see how comparable those scores are. So the higher the number, the higher, closer to 1, the better comparability or more reliable the score is. Again, this is older data that the developer had provided. So you can see that what's called an interclass correlation coefficient is that sort of comparison indicator, and that was at 0.14. So we drew that 0.1494. We drew attention to that as part of why this measure was not met. But the data also had some data element testing as well, which looked pretty good. There was also no updated data provided, so all of this testing was more than 10 years old, which was also a limitation that was pointed out here. There was some discussion of face validity that was established by the TEP, but there's no results reported. Face validity is usually something we do see for new measures, or a lot of times when significant changes are made to maintenance measures, there may be a panel that developers convene to provide more face validity estimates. So that's why it was not met. Drawing attention to what those limitations are also listed on the slide here. But I just wanted to check in here. Okay. Does anyone else have any comments on sign of acceptability? And we talked a lot about the reliability here, but there's also validity, if you have any validity questions or concerns. Any issues here? So I don't know, Heidi or Katie or others, I think this is kind of where we are with the data access issue. I don't know if there's anything else you wanted to touch on, maybe the split half reliability that was done a while back. I don't know if there's any comments on that, but anything you wanted to say about the limitations?
Sure, I'm not a statistician, so I'm going to turn this to Jeptha or Carl to answer the split half and see if they have any insights into what they found in the original testing.
Yeah, that's Jeptha again. It's going back many years, so it's a little hard to recall. At that point, I think a different threshold had been established for sort of, actually it was just fuzzier as to what was adequate reliability. And I think we had met it on those prior endorsement and re-endorsement in 2016. I know some of the issues that we had were that the data we were using to assess reliability came from, I think, as you mentioned, indirect linkages. And so there was a lot of, a fair number of hospitals where the number of procedures was lower than what we had expected. And I think that limited as we then split the sample to become more challenging. So, I think all we can say right now is we don't know the reliability of the measure in its current form. And that would be something that if we can find a pathway to keep this measure on life support until a mechanism for obtaining the appropriate data becomes available, then we would, of course, need to do testing to, make sure that the codes that we're using to identify the outcomes are still valid, that the reliability and validity of the measure is adequate. So I'll leave it at that. But yeah, I don't think we can say right now in the current era that this is reliable.
So also mentioning the need to do some updated testing on the measure, which I'm going to ask Mary Beth or Whitney. I don't know if there's any additional questions you have. I'll draw attention to Kurt. He dropped his comment in the chat. So Kurt did serve on a prior contractor or the NQF cardiovascular committee when this measure originally came back through in 2016. He said it was a difficult measure, but I would be in support of endorsing it with a follow-up on some of these numbers. So originally endorsed in 2011, re-endorsed in 2016. There could be some annual updates were completed along the way. The data, they were good or better for science, feasibility, use, usability, validity. And having recently worked 10 years in cardiology care, I saw similar rates of complications in our hospitals. So coming from Kurt. So he would suggest endorsing with, I think you said exceptions, Kurt, but I think you might conditions on the following up on data and more stringent monitoring. And then Ben Shirley also mentioned, is empirical validity testing considered a requirement for endorsement and maintenance? That is a question for Patel. So it's not a requirement. It's not a requirement. There's sort of an expectation we'd like to see empirical testing. I believe actually, Ben, I think you might have been referring to measure score empirical testing. That is not necessarily a requirement. But it is something that we are wanting to start seeing maintenance measures provide. Moving forward, we may start to evolve the criteria to require that type of testing, working with our scientific methods panel to get their input as well. But that's why looking at the older data back 10 years plus ago, and looking at the testing they have provided then, if care practices haven't changed anyway, is that still an acceptable are those still acceptable testing results? And we talked about the IC or the split half being a little bit low, and the developer had commented on that as well. Yeah, thanks, Kurt. And yes, Ben did confirm score level reliability. So right, score level is not required currently under the rubric, but it is something we want to start seeing with maintenance measures. That's why these conditions that to be placed on these types of measures. But I think what we're hearing is there's a lot of access issues of the data to really consider with this measure. Any other comments? And I'm going to, Mary Beth, Whitney, anything that you kind of saw through the committee reviews, or any questions that you maybe think might be helpful for scientific acceptability?
Well, I don't have any additional questions. Thank you for the presentation, Heidi.
similarly, I think we're all kind of sitting with the burden that you all have been carrying.
Yeah. Okay. All right. I'm not seeing anything else that come through. Okay, so there was a question coming through. CMS gets its data from states, and 48 states are reporting to AHRQ and HCUP. Have you explored that route? So asking if you've explored additional data sources for this measure.
To be honest, I'm not sure if ACC has looked at the ARC or HCUP data. Katie or Christina or Jephthah, are you aware?
I don't think we've looked at that specifically, but predominantly I think the issue is the direct linkages and being able to use direct identifiers. Anytime we're going to hold hospitals responsible for the outcomes, we want to make sure with as close to 100% certainty as possible that we're linking the right patients. And so I think that's why we needed to get the data as directly from CMS as possible. You know, we've been able to use ResDoc data for research purposes. We just haven't been able to use it for implementation of this measure.
Okay, thank you. Any other comments, questions here on the scientific acceptability? Okay, so it sounds like if there was a condition to be placed on this measure, I'm so far hearing about the condition about updating the performance gap information. If you have access to the data. The other condition, I think what I've been hearing is obviously updating the testing information to ensure that the measure still is reliable and valid, especially if anything has changed as far as care practices. But Heidi and Katie, any disagreement with those, any concerns with those types of conditions if that was to be placed on the measure?
No.
Okay. Okay. Let's move to the next domain here, which is just equity. This one, again, is optional, not addressed. So 100% of those respondents said not met on here, being an optional criterion. But does anyone from the committee have any thoughts on equity, on disparities with this measure? Anything that could be considered by the developer, recognizing that there are some data limitations and challenges? Okay. All right, not hearing any. We'll go to the last domain, which is use and usability here. This one, we also, for the staff preliminary assessment, also had not met, and that's also reflected here. And the reason being is it's not being used. So the developer had confirmed that. And so it's hard to understand if there's any feedback mechanism related to that use, and also if that measure is changing care practices and moving the needle in any way. There's no data to report that out, so thus not being met. So you also saw that with the coming through here, noting those same limitations. But from Heidi and Katie, anything addition to add here? I think the data issue is really the key piece.
No, we wish that we were presenting a very different submission, just quite frankly. And thank everybody for taking the time to take a look at this. We appreciate it.
Thank you.
And Matt, pulling from submitted comments, I just wanted to make sure that I put on the record for everybody, one of the comments that was received was just that this has been a lengthy stretch of time. And in that time, a patient with ICD may be part of a downward trend in something that any one of us could be mobilizing to fix and address in a faster way. And so whatever we can do to try to resolve this collectively would be very significantly welcomed. I realize that's outside of a quality review committee and, this technical piece, but it sounds like there's a pretty urgent need over at ACC to see this happen. And get this done. And from the patient community space, this means that there's a huge 15-year gap in folks being able to provide care to them and see what's happening with their care.
Thank you so much, Whitney. So if I'll ask the developer. Obviously through these evaluations, I'll mention this to the committee again. If you go through the rubric, you're answering these questions based on the confidence that you feel that this measure has met those domains of the rubric. And that's how you're endorsing this measure based on any of these concerns with the data, or you think these concerns can be alleviated through some of these conditions. But I wanted to ask the developer, if the measure did lose endorsement or was removed, is it something that it would not be able to come back? You're not saying it would be something that would come back to the CBE for new endorsement consideration once you have the new data? Or having the endorsement designation helps with whatever implementation or use or anything that you need to bring to Congress to get data?
Katie or Jephthah, any thoughts on that? I think it's a challenge either way. Continuing endorsement continues to show the importance and the priority of the outcome. Removing endorsement has another message as well. I don't know how it would be interpreted. Jephthah or Katie, any thoughts?
I mean, I don't know if it's going to affect the legislative processes in any meaningful way, one way or the other. My read of the tea leaves at ACC, and certainly I'm an individual here, not talking about on behalf of the organization. The burden and lift to get a measure de novo through is very high, and there are lots of measures that we could consider. I think it might make us less excited about starting from scratch, and I think the energy necessary would be lower if we were looking for re-endorsement, or can make a stronger justification for it if it's already been endorsed or continues to be endorsed. But again, that's more of a guess and an estimation than any promise.
Thank you. And then with these conditions that we've been hearing, obviously updating the performance gap information, the testing as well, and looking at improvement results, hopefully. Under the TEL process, the full formal evaluation is something at 5 years. But based on some initial discussions about getting some access to data, maybe could be coming a little bit sooner. Would a condition, in addition to those data pieces, also be time frame? And so something around more like a 3-year turnaround as opposed to waiting for 5 years. I'd like to see what the committee might think on that. And so if you are going to endorse with conditions, putting also this timeline of wanting to have the measure come back through prior to the 5 years, which would be something maybe around 3. If any thoughts from the committee on that in addition to those other conditions? So you're just having the data access and then wanting to come back earlier rather than 5. And then I'll also see if the developer, see if that's a feasible thing that they think could happen. Any disagreement from the committee or anything on that? Mary Beth, yeah, go ahead.
Yeah. If the Congress does not give you what you need, how feasible is this measure to you all? I'm asking the developers. Is this dead in the water then? Or do you have other areas that you could possibly explore or tweak it, or any of that?
Well, I think, and Jephthah, jump in, but there is the inpatient model already available, so that could come forward. But we acknowledge, as Jephthah said, that doesn't cover the full kind of time frame that's most important. Jephthah, anything you would say, add?
Yeah, no, I think it has to have the follow-up, and voluntary follow-up, as Christina said, is something we've considered. It's a non-starter. We're just not going to get reliable information from our hospitals. It has to be some sort of external third party that is reliable, and that's what we had with the admin data.
But the registry data doesn't give you some of that at all, or no? Or yeah?
It gives the inpatient. Christina, do you want to? There is some additional timeframes where things are captured. but I don't believe it's very complete. Anything, Katie or Christina, you could add to that specifically?
In other registries, like other registries are mandating through CMS or FDA that the follow-up data is captured based on the device intervention. This specific registry unfortunately doesn't mandate a follow-up, and because of the burden on the hospital, it's just not done.
And when we were, when we started this measure many years ago, we did consider whether or not the in-hospital piece would be sufficient. And the overwhelming feedback from our technical expert panels and our own consensus was that it's just too important to have to know what happens after discharge.
Okay, yeah, I'm not familiar with ACC's registry, but actually my mother had one of these and she had to go to the doctor's office to get that followed up, not the hospital. So what I was thinking is maybe that would be an opportunity for you all to expand your registry to some of the offices that, for follow-up as such. So just a thought.
Okay. Thanks, Mary Beth. Any final comments, thoughts from the committee on this measure? Okay. Our colleagues from ACC, any final comments on this measure before the committee goes to vote and we explain what the conditions are? Oh, I did want to ask, we probably, like that 3-year timeline, right? So, we're doing the 5 years for the full formal maintenance review to allow for, testing and things like this for other conditions. But, with this measure being as old as it is and, this trying to get more updated data, with 3 years, that timeline seems feasible. Obviously, it depends on the data access. But if you were to get data to update these figures, is that a feasible timeline?
I think ACC would make every attempt to meet that 3-year if they are able to get access to the data. It would be a sprint, but they would make the commitment to try to do that if they could. And we apologize for giving you such a conundrum the first time we come forward with the measure. It's unfortunate. This is not the norm for ACC.
Thanks, Heidi. Okay. But yes, ACC, any final comments for the committee besides that? Okay, all right. So we will be going to vote. Again, a reminder that Jason Lasky, you are recused, so you won't vote on the measure. The conditions that will be placed on the measure will be to update the performance gap as well as the testing for both the reliability and validity, to look at obviously the data elements, and if the developer is able to do so, consider exploring the measure score level. Again, that's not necessarily required, but we would, I think it would be preferred to also have that information as well. And then any sort of improvement results that could potentially be gleaned from this. So that is going to be, those are going to be the conditions, which is really reliant on the data. And then the measure would be coming back at a 3-year time point. Okay, all right, so let's go ahead and open up the vote.